One about triple negative breast cancer, and the second one about hormone receptor positive HER2 low breast cancer. So I would like to welcome Dr. Ahlam Dohail, the moderator for first session.
Check.
You can keep it there.
Good morning, everyone. يعطيكم العافية. Would like first to thank Moosa Group for arranging such a nice session and the organizing and scientific committee. Our first speaker will be Dr. Mshari Zahrani. He's a consultant medical oncologist at King Faisal Specialist Hospital in Riyadh, and he will be talking to us about the early triple negative breast cancer.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. for this introduction. Today I'm going to talk about triple negative breast cancer. So this is the outlines of my talk today. I'm going to talk about an overview, then small, early stage triple negative breast cancer, specifically less than 1 centimeter, and preoperative and also post-operative management and future directions. So, as we all know, that triple negative breast cancer carries worse prognosis when compared to other subtypes of breast cancer. The likelihood of distant recurrence after surgery declines after years, and the peak of triple negative breast cancer recurrence usually within 3 years. So triple negative breast cancer is not one disease. We have different types of triple negative breast cancer. The basal cell-like, which is the most common, and it carries worse prognosis compared to other subtypes. But I want to draw your attention to the immune-enriched subtype of triple negative breast cancer. So in immune-enriched triple negative breast cancer has high infiltrating lymphocytes, tumor infiltrating lymphocytes, which is prognostic in triple negative breast cancer and HER2 positive as well. It predicts higher PCR rate, and patients who has high tumor infiltrating lymphocytes usually do better as they respond better to chemotherapy. So in this trial, which examined non-anthracycline-based chemotherapy, patients who has high TILs, patients who has high TILs, specifically more than 30%, they achieved high PCR rate, around 74%. And this is the other subtype, although we don't have any solid data to treat HER2 low triple negative breast cancer in early stages. What about ER low tumors? So we have data suggesting that ER low breast cancer, I mean ER between 1 to 10%, behave similarly to triple negative breast cancer. And this Sweden study revealed that ER low breast cancer respond to neoadjuvant chemotherapy similarly to ER negative breast cancer, around 30% PCR rate, comparable 25% PCR rate compared to the ER negative breast cancer, who achieved 30% PCR rate, unlike the ER positive, where they achieved just 8.3% PCR rate. Also, the outcome post-neoadjuvant chemotherapy and surgery, ER low tumors tend to have behavior similar to triple negative breast cancer in terms of recurrence. So what about small tumors, T1A and T1B? Should we treat those patients with chemotherapy or just observe them? This is an older series. It was reported from MD Anderson. They included all subtypes of breast cancer, but there was around 1,000 patients with triple-negative breast cancer. 150 patients among them had T1A and T1B combined. So it appeared that patients with T1A and T1B tumors did not gain additional benefit from chemotherapy. And this is a newer series where they included around 8,000 patients of breast cancer, and they looked specifically into the triple-negative subgroups with small tumors, less than 1 centimeters. Patients who had T1A tumor did not gain additional benefit from chemotherapy. The same thing here with T1B tumors. However, once the tumor is more than 1 centimeter, like in T1C subgroup, they had small benefit from addition of chemotherapy. Now I'm going to talk about the preoperative management of early stage triple negative breast cancer. We have the atezolizumab trial, which is Ambition 030 phase 3 trial. They randomized patient between chemotherapy in addition to atezolizumab versus chemotherapy alone. The study was conducted after surgery, and it did not show a significant difference by addition of atezolizumab to the chemotherapy arm. However, in Keynote 522 study, which is currently the standard of care, where they included patients with stage 2 and 3, from stage 1 to stage 3 triple negative breast cancer, but tumor has to be more than 2 centimeters in node-negative disease or more than 1 centimeter with node-positive disease. They randomized patients between chemotherapy in addition to pembrolizumab versus chemotherapy and placebo. Patients then after surgery continued to receive pembrolizumab in the pembrolizumab arm. So this is the baseline characteristics, which is comparable between both groups, and this is the event-free survival at interim analysis update. There is significant event-free survival difference between the pembrolizumab group and placebo group, and this was seen among stage 2 and stage 3 patients. Again, in nodal positive or nodal negative, they gain similar benefit. And when it comes to the PCR rate, this is the last update in San Antonio last year. So there was difference even among patients who achieved PCR rate, around 5% difference in stage 2 and 4% in stage 3. In patients who did not achieve PCR, they gain benefit from continuing pembrolizumab in the adjuvant setting, but in patients who received PCR, they achieved benefit, but small compared to the non-PCR patients, which is expected. So this was seen also in node-positive disease. So regardless of the nodal status, patients who achieved PCR rate, they gained small benefit from continuing pembrolizumab in the adjuvant setting. What about node-negative disease with patients with node-negative and T2 disease? There was question regarding this intensive chemotherapy regimen for this subgroup of patients. However, in Keynote 522 trial, they gained also clear benefit from addition of pembrolizumab. This is the distant recurrence rate among patients who received pembro versus no pembro. It's again in favor of pembrolizumab group, and also in brain metastasis, although the number was small. So patients who did not receive pembrolizumab had more distant recurrence in brain. So the study team concluded that addition of pembrolizumab lead to different and event-free survival among patients who receive pembrolizumab regardless of the nodal status and regardless of the stage. However, follow-up for overall survival is still ongoing. So this table summarizes the studies that used immunotherapy-based regimens in preoperative setting, high-risk triple-negative breast cancer. We have clearly improvement in event-free survival in Keynote 522 trial. However, in other trials, specifically in Passion 031, the event-free survival was not reached, but the PCR rate was promising. It was in favor of addition of atezolizumab. And in new TRIP trial, it was the only trial that did not include anthracycline-based therapy. All other trials, they added anthracycline as part of the preoperative regimen. So what about the escalation of treatment in patients who have BRCA positive, for example, or patients with early stage disease? So this small study, which is kind of thought-provoking study, they used chemotherapy-free regimen preoperatively. They used lazoparib, and the PCR rate was promising actually in patients who received lazoparib. It's almost comparable to chemotherapy. So this study is ongoing right now. They included BRCA positive patients with tumor of T1C or more, and they randomized them between niraparib versus niraparib plus dostarlimab, and they did not give patients chemotherapy. Still ongoing. We don't have any data, but the expectation is that addition of PARP inhibitor instead of chemotherapy in this subset of patients may give similar result to chemotherapy with less toxicity. The new STOP study examined the anthracycline-free regimen, although the sample size was small, just 100 patients, and they randomized patients between carboplatin and taxane versus carboplatin and tocilizumab versus carboplatin and docetaxel. It showed promising PCR rate. It was almost comparable between both arms. So this study, the new TRIP study, it is a negative trial. The PCR rate by addition of atezolizumab to non-anthracycline-based chemotherapy did not reach the statistical significance. This is small, the new PACT phase 2 clinical trial. Again, they incorporated anthracycline-free regimens, and it showed promising PCR rate, and patients who achieved PCR, they do extremely well, as we can see in the figure on the right. So this triggered the SCARLET study, which is still ongoing. They randomized patients between immunotherapy plus chemotherapy versus, chemotherapy including anthracycline versus anthracycline-free regimen with addition of immunotherapy as well. The unique about this trial is that after surgery, patients who received PCR, they continued pembrolizumab, but patients with residual disease, they received additional chemotherapy. So still we're waiting for the results of this trial. So the question here, can we give less or no chemotherapy to selected triple-negative breast cancer tumors? This is small series of patients who have stage 1 disease and high TILs. They did well even without chemotherapy. So it's again a thought-provoking. There might be subset of patients who don't need chemotherapy even if they have aggressive triple-negative breast cancer. So what about post-operative adjuvant therapy? We all know the Olympia trial, which included patients with BRCA1 and 2 mutation. They included both triple-negative breast cancer and hormone receptor breast cancer, hormone-positive breast cancer as well. The patients were allowed to receive neoadjuvant chemotherapy or adjuvant chemotherapy, but for patients who receive neoadjuvant chemotherapy, they had to have residual disease in the triple-negative breast cancer, and in hormone receptor positive, they had to have residual disease in addition to CPS EG score of 3 or more. So patients were randomized between olaparib versus placebo for 1 year, and the invasive disease-free survival was the primary endpoint for this trial. It was significant in favor of olaparib, and also the distant disease-free survival was, there was significant difference in distant disease-free survival in favor of the olaparib group. Again, even in overall survival, there was 3.8% improvement in overall survival at 36 months in favor of olaparib. So it's standard of care to offer olaparib in those patients who had residual disease and triple-negative breast cancer. We all know the CREATE-X trial. It gave positive results, especially in triple-negative subgroup. So patients who had residual disease and received capecitabine for 6 months post-operatively had better outcome. But the question remained that how can we choose the adjuvant or post-operative therapy in this subset of patients? We have capecitabine, we have the pembrolizumab as per Keynote 522, and we have the olaparib in BRCA1 and 2 mutation patients. So this is the current practice. Patients usually receive pembrolizumab in addition to chemotherapy in preoperative stage, and after surgery we have 3 options, whether capecitabine, olaparib, and pembrolizumab. Can we combine those medications? We don't have an answer for that, but we have trials. It's in different subsets, most of them in metastatic setting, looking into combination of olaparib and pembrolizumab, for example, and it has been shown to be safe. So most clinicians combine olaparib and pembrolizumab for non-PCR patients, for example, if they have BRCA1 or 2 mutation. If patients has significant residual disease despite neoadjuvant pembrolizumab and capecitabine and chemotherapy, one may consider addition of capecitabine for those patients. Regarding the adjuvant pembrolizumab, the question was raised about efficacy of adjuvant pembrolizumab, whether this is the effect of the adjuvant pembro or the effect of neoadjuvant, because we have other trials that showed adjuvant immunotherapy did not add additional benefit. And this study is conducted by Dr. Sarah Tulaini. It's looking to this specific point. So patients who achieved PCR are randomized between pembrolizumab for 8 cycles versus observation. And this will answer the question regarding adjuvant immunotherapy in PCR patients. So there are several trials trying to improve the outcome of patients with residual disease after neoadjuvant chemotherapy. Sashia trial, for example, they looked into addition of sacituzumab versus treatment of physician choice in the adjuvant setting. Another trial, which is TROP2 ADC, they are looking to DXD plus durvalumab versus DXD alone versus investigator choice of therapy. And another trial, which is the ASCENT-05 trial, it's ongoing right now. They included patients with residual triple-negative breast cancer after neoadjuvant chemotherapy and surgery. The patients were randomized 1-to-1 to sacituzumab plus pembrolizumab versus treatment of physician choice and pembrolizumab. So what about minimal residual disease monitoring, which is the tumor, which is the circulating DNA post-neoadjuvant chemotherapy? Data has been shown that patients with detected cyclic tumor DNA after neoadjuvant chemotherapy do worse compared to patients who has negative cyclic DNA. So should we offer more treatment to those patients, like adjuvant chemotherapy, for example? Still, I mean, a lot of work is ongoing to answer this specific question. So what's the future directions in early stage triple negative breast cancer? We have the Alexandra trial or Impassion 030, which did not demonstrate any benefit from adjuvant immunotherapy. And based on that, the optimal ICE PCR trial will look to this question specifically about adjuvant immunotherapy in patients who achieved PCR. We have the Scarlet trial, which is still ongoing. It will answer the question of benefit of anthracycline-based regimen versus non-anthracycline-based regimen. And also we have the antibody-drug conjugate, which is mainly for patients who did not achieve complete response post-neoadjuvant chemotherapy. The ASCENT-05 trial combined both antibody-drug conjugates, sacituzumab, govitecan, in addition to immunotherapy. So this is the end of my talk. Thank you very much for your attention.
Thank you, Dr. Mishari, for the excellent overview. We'll keep the question and answer till the end of the session. First of all, I would like to thank Dr. Ahmed Al-Wabari for the kind invitation and all the organizers for the great organization and kind hospitality. Now it's my pleasure to introduce our next speaker, Dr. Osama Halawi. Dr. Osama is a consultant medical oncology in Johns Hopkins Aramco Hospital in Dhahran. He will give us a talk about the role of antibody-drug conjugate and immunotherapy in metastatic breast cancer. Dr. Osama, the mic is yours.
Good morning, and thank you for inviting me to give a talk about metastatic triple-negative breast cancer. I know you had a long night last night, but I made a mistake in this slide. And to measure your caffeination, where is this mistake? The B in cancer, right? You are not caffeinated enough. It was an honest mistake. Anyway, at least I put the letter B and not the letter D. So let's be serious a little bit. So triple-negative breast cancer. Okay, thank you. Triple-negative breast cancer, it's de novo in 30% of cases, which means present as metastatic disease. And for many years, chemotherapy was the only thing that we could offer. Most patients have been exposed adjuvantly or neoadjuvantly to anthracyclines and taxanes, and more recently carboplatin. Almost 70% of patients will relapse after initial treatment for early disease, and they are usually having a visceral disease, lung and liver metastasis, and that's why they end up living shorter than hormone receptor, which present mainly with bone metastasis. And there is high attrition rate from first to subsequent lines of therapy, which means that your first line of therapy will be your most effective, will give you the highest response rate, and will give you also the longest duration of response. The best treatment for them is to include them in clinical trials if available. So again, stage for stage, when you compare triple-negative breast cancer to hormone receptor to non-triple-negative breast cancer, you can see stage for stage, the outcome is worse for triple-negative breast cancer. And it is a heterogeneous disease. It is known for what it does not have, not for what it has. So it does not have ER, PR, or HER2/neu. Now we are looking at other variables that could affect our treatment, such as the PDL1, the BRCA mutation, and the tumor lymphocyte infiltration, like my colleague Mshari indicated, and disease-free interval from prior therapy determine the prognosis. And next generation sequencing is rarely helpful in this setting. So we have new targets in triple-negative breast cancer. The targets are immune therapy, PARP inhibitors, and the ADCs, the antibody-drug conjugates. I'm going to be talking about immune therapy and antibody-drug conjugates, and next will be the PARP inhibitors. This is the NCCN guidelines, and we can see the first line. If you are, just to put things in perspective, if your CPS score is 10 or more, then your first line treatment will be chemotherapy with pembrolizumab. And if you have a germline mutation, then your initial treatment will be PARP inhibitor, olaparib or talazoparib. This CPS score more than 10% and germline mutations will make up only 40 to 45% of the patients. So 55 or 60% still have no target. So we see the second line, which is sacituzumab, govitecan, and Enhertu. It's easier to say Enhertu than famtrastuzumab deruxtecan. So, this is a little bit about the anti-tumor immunity. The cancer cells will die spontaneously with apoptosis. They will expose antigens, and these antigens will float in the circulation, will go to the lymph nodes, and will be presented to the lymphocytes. Then the lymphocytes will be trafficking back into the circulation, back into the tumor to infiltrate the tumor, and it will recognize the tumor and kill the tumor. The tumor is smart, of course. They will have different mechanisms to escape the killing of the immune cells, and these mechanisms are partially controlled by anti-PD-1 or PD-L1 or other checkpoints inhibitors such as CTLA-4. Breast cancer is not known to be the most immunogenic tumor. We know that melanoma is the most, and lung cancer, non-small cell lung cancer, is the second most. And if you look at the environment of the cancer cells, we can describe it as immune desert or immune excluded or inflamed. Immune desert, there is no infiltrating lymphocytes or immune cell. Immune excluded, there are lymphocytes or immune cells in the tumor, but they are not engaging or infiltrating into the tumor. Inflamed, where the tumor there are immune cells, and the immune cells are not activated yet to attack the tumor. Clearly, some people stayed up late last night. Wabari just arrived. What time did you go to bed, Wabari, last night? 3 a.m.? Keep going? Okay. So, like Dr. Mshari said in the early talk, that neoadjuvant chemotherapy can increase your tumor-infiltrating lymphocytes. And we can see pre-neoadjuvant chemotherapy that tumor-infiltrating lymphocytes increased with subsequent biopsies. Again, this is kind of repetitive. How do we trigger or change the environment? Again, chemotherapy, PARP inhibitors, and antibody-drug conjugates are the three things that we could use to treat triple-negative breast cancer. We will activate the immune desert environment. We will recruit T lymphocytes, and the lymphocytes will be infiltrated into the tumor again, and the PD-1 will change the environment from immune excluded to immune inflamed. So this is by release of cancer antigen, reduce or down-regulated T-regulatory T cells, and increase PD-L1 and CD8 positive T cells. So the first study, which is the Impassion 130, and I will go over this quickly because it was a negative study. It was atezo with nab-paclitaxel versus nab-paclitaxel alone. Initially, it was positive, but they were required to do additional studies to get the FDA approval. And the additional study, again, there was some overall survival advantage with the Impassion 130 again, atezo, NAB, paclitaxel with or without atezo. The subsequent study was Impassion 131, and this failed to show any improvement in overall survival or progression-free survival. And the drug was dead in triple-negative breast cancer so far. So we don't know why. Some people, I'm not an expert in statistics, but they think the statistical design of the study was not done in a way to show efficacy. PD-L1 was suboptimal for atezolizumab. The paclitaxel arm did very well. The control arm did very well. And the different chemotherapy, I don't think this is relevant or true that giving steroids with Taxol help decrease the immune reaction from the anti-PD-1. So this study is, of course, changed our practice. It's a pembrolizumab, Keynote 355, pembrolizumab with chemotherapy as a first-line treatment. Again, triple-negative, first-line. PD-L1 expression was looked at, and the randomization was 2-to-1. Pembrolizumab was given every 3 weeks, and physicians have choices. Okay, they did not have one limited drug to use. It was treating physician choice, which is very smart because some physician will use taxane, some physician will use gemcitabine or carboplatin, and chemotherapy that were used, NAB, paclitaxel, or gemcitabine, or carboplatin. Okay, and we can see here that the baseline are similar in the two groups. Median age is 53, which is young, and the distribution of CPS parameters like more than 10 or more than 1 was also similar, and the distribution of chemotherapy was also similar. This is by CPS score more than 10, progression-free survival. We can see that if you look at it more than 10 or more than 1, they all benefited. But when they break it down a little bit further, they found that most of the benefit has come from the CPS more than 10 and not more than 1. And there was no significant difference when the CPS more than 1. And further look at CPS, they looked at CPS, maybe the benefit is coming from the patients who are more than 20. They found more than 20 and more than 10 are equal, so the FDA approval came for CPS more than 10. So any patients with CPS score more than 10, triple-negative breast cancer, you have to consider pembrolizumab with chemotherapy. And it didn't matter, the only thing that is did not really cross is if you look here, disease-free interval, if they are less than 2 months from previous chemotherapy, they did horrible. So these fast relapsers are not going to do very well with the immune therapy. But still, if the CPS is more than 10, you probably have to use it. And I don't know how we're going to use this information in the future with these patients receiving pembrolizumab in a neoadjuvant fashion. Because now the pembrolizumab, these patients, none of them received pembrolizumab in the perioperative setting. So this is to be determined later. And I will this is to compare between the trials. So the take-home message is pembrolizumab, CPS score more than 10 is because of the survival advantage and the PFS advantage, it is your first-line treatment. And this compromises almost 35 to 40% of your all patients with the triple-negative breast cancer. So the next thing is, again, this is to summarize what we just said about the PD-L1 and early relapsers, we need more effective options, and further predictors need to be evaluated, not only the CPS score. I'm going to move to antibody-drug conjugates, and we have 2 antibodies that I will be talking about. So just the molecular components of the antibody-drug conjugates, there are different types. There is the antibody, there is the linker, and there is a payload. And you can integrate any of these things to get an antibody-drug conjugate. It's always IgG, could be IgG1, 2, 3, 4, usually IgG3. And there is the linker, and the linkers are cleavable and non-cleavable. Usually they are cleavable, but how do they get cleaved? Either by acid cleavability or reducible, or proteasome cleavable, which is enzyme cleavable, which is the case of Enhertu. And there is the payload. And most of the payloads now are the topoisomerase inhibitors with the chemotherapy drugs, with the ADCs used for breast cancer. So again, this is another graph to show you that this is, in this case, that's a C2zumab, the TROP2, okay, the binding of the antibody to the receptor, and then internalization, degradation of the antibody drug conjugate from the payload, release of the payload, killing the cancer cell, and there is a release of the payload or the drug from the cancer cell and killing of neighboring cells. This is called the bystander effect. And this also can enhance the immune environment in the tumor. So two drugs, sacituzumab govitecan and trastuzumab Enhertu. They're both approved for second lines. And we can see here the NCCN guidelines, sacituzumab and famtrastuzumab, both are used in the second line. I mean, I don't want to say what's my preference, but I will show you the evidence. Okay, the ASCENT 01 trial, it's a randomized double-blind placebo-controlled trial, phase 3. It's all patients who are triple negative, and they have received 2 or more prior systemic therapy, at least one in the metastatic setting. And they had no evidence of brain metastasis at the time of study, or active brain metastasis. Again, it was a 1-to-1 randomization, and the sacituzumab is given day 1 and day 8, and the chemotherapy, again, they did not limit physicians with the choice of the chemotherapy. And we can see that there has been significant improvement in progression-free survival, okay? And we can see the response rate to sacituzumab in the waterfall curves is significantly better than the chemotherapy or treating physician choice. And the lower right quarter is showing the progression-free survival in the whole population, and which is significantly better in the sacituzumab govitecan. Again, the sacituzumab, it binds to TROP2 receptor, and the govitecan is a topoisomerase inhibitor, which is N38, which is the same like irinotecan, and this is to keep in mind for the next antibody. Again, this is sacituzumab. The median overall survival was doubled with the use of sacituzumab from 6.7 to 12.1. And actually, I'll go back. And it's very nice to see that 2 years overall survival is a quarter of the patients are still alive at 2 years with the sacituzumab versus 5% of the patients in the treating physician choice. Next, and it's also it's important to look at the patients with HER2 low, because this is the antibody drug conjugate in Enhertu is designed for HER2 low. And we can see that even in the patients with HER2 low, where we have another option, there has been improvement in PFS, similar to the others. So HER2 low also are responding to this drug, because TROP2 is also present in HER2 low. TROP2 is definitely present in most of the, whether they are HER2 low, hormone receptor positive, or triple negative. It's expressed in all. There is no need to check for TROP expression. Side effects, diarrhea and neutropenia, and it does cause alopecia. So you need to monitor if the patient has unusual toxicities. You need to worry about UGT mutation, which is not common. Again, this to summarize things, improve median survival with an overall response rate of 33%. The second one is the famtrastuzumab, which is again, it's another topoisomerase inhibitor. It's the same payload or the same mechanism of action for the payload with the sacituzumab and the famtrastuzumab. The linker is enzyme cleavable, and the ratio is 1:8, and the receptor is HER2/neu. You know, even in patients who are labeled HER2/neu 0, there is expression of HER2/neu that we cannot detect by immunohistochemistry, but there is expression of HER2/neu. That's why there is an ultra low and what's not. And the HER2 definition, positivity or not positivity, and I tell this all the time, it was made based on the response to trastuzumab. So it's only designed to see if this patient is going to respond to trastuzumab or not, but not to response to antibody drug conjugates such as famtrastuzumab. Again, this is the trial, the Destiny Breast 04, and actually, it's not a triple negative patients trial. Only a small percentage of patients in this trial were triple negative. The majority of them were hormone receptor positive. So when you think which drug you're going to use, you have to consider this information. Again, it was a 2-to-1 design, and HER2 is given once every 3 weeks. The other drug was given once every day 1 and day 8. And again, different choices for the physicians to choose from. And the endpoints were PFS. We can see in progression-free survival and hormone receptor, positive. It was significantly better in the trastuzumab, famtrastuzumab arm versus the physician choice. And it was also better in the whole population. I could not see the curve for the triple negative patients only. There is no such curve. So you have it's lumped in the top curve, or the bottom curve, sorry, in the all patients. And the same thing for the overall survival. They break it down by hormone receptor and all patients. I did not see the curve for the triple negative. And again, there is improvement in overall survival for the famtrastuzumab, 23 months, and for the physician choice is 17.5. In the other study, it was shorter, but the other study was purely triple negative patients. In this study, it was hormone receptor, which is known to do a little bit better. Again, improvement in overall survival in HER2 low metastatic breast cancer. Part of the group was triple negative. And this is the only table I saw where there is some information specific about hormone receptor negative. The far right, TDXD versus treating physician choice. There is no statistical significance difference, but again, we cannot draw conclusions. But there was, when the hormone receptor positive or the whole population, there was statistically significant difference in progression-free survival and overall survival. Again, the FDA approval was for both. The adverse reactions, again, nausea, vomiting. I have to say, sacituzumab and famtrastuzumab are moderate to highly emetogenic medications. So you need to use your big guns anti-nausea medications with them. And it does cause myelosuppression, of course, and hair loss. Now, what I said is, again, to summarize, is Pembro, first line for CPS 10 or more, sacituzumab and famtrastuzumab, second line for all patients. What is going to come next? Nothing is approved. It's all just thought-provoking and ongoing clinical trials. Combination targeted therapy. How do we combine antibody drug conjugates with PARP inhibitors? How do we combine antibody drug conjugates with immune therapy? With PARP inhibitors, you know, it seems to make sense once you have a DNA damaging agent to give PARP inhibitor in addition to the DNA damaging agents, which is in this case sacituzumab, to prevent the repair of the DNA. And this trial, it was looking, it's a small trial, but was looking at giving sacituzumab govitecan with PARP inhibitors and thinking that this will increase the cell killing by increasing the exposure or decreasing the repair of the DNA. And they gave the talazoparib with the sacituzumab in two fashions, concurrently from day 1 to day 21, or in a staggered schedule, which is only from day 15 to day 21. And the concurrent was totally disastrous. Dose limiting toxicity 71%, and the staggered was no dose limiting toxicity. And there was some responses. It's a thought provoking, it's not standard of care, but I'm sure we will see more. And the other thing is combining antibody drug conjugates with immune therapy. Again, we went through this in different diagrams. I will just go quickly to the Begonia trial. And the Begonia trial is a multiple arms study. It's about the datopotamab DXD. It's the same payload like Enhertu, but different antibody. It's TROP2 antibody with DXD. In this trial, I want you to focus on arm 7, 30 patients. At the time of the analysis and was presented at the last ESMO, 29 patients were still in the drug. I want to go fast because I know I'm over time. Response rate, first line, triple negative metastatic disease, durvalumab with dato-DXD 79%. This is amazing. And it has nothing to do with the CPS. Regardless of your expression of CPS or PDL1, you responded. I think we will see more in the future, and bladder cancer was very promising when we combined immune therapy with antibody drug conjugate. And we can see the median duration of response is 15 months and PFS is 13.8 months. This is the conclusions from the trial, which is basically going to lead to more trials in this direction. The other combination is TDXD with nivolumab. HER2 low, HER2 positive, we also see excellent responses. I think the two combinations were very also well tolerated. And datopotamab with deruxtecan, and this is the ongoing trial. Again, we don't have final results, but it's an antibody that we may see also in triple negative breast cancer. And this was first line, of course. And the other trial is sacituzumab, which is the ASCENT-4. And there is an ASCENT-4 and ASCENT-3 trial. The ASCENT-3 trial is sacituzumab with pembrolizumab versus pembrolizumab alone. And with this, I will stop. Thank you very much.
Thank you, Dr. Osama, for this elegant presentation. And again, we will have the question at the end. Now we will move to our next lecture, which will be the role of PARP inhibitors in metastatic breast cancer. Our presenter is Dr. Osama Abdul Jalil, a consultant medical oncology at King Fahd Specialist Hospital, Dammam. Please, Dr. Osama.
Thank you, Dr. Abdul Muttalib. Thank you, Moosa Group and Dr. Wabari for having me. Definitely a pleasure. My talk is focused about the use of PARP inhibitor in breast cancer. This is my disclosure. So BRCA1 and 2 remains the most common identified pathogenic variant in hereditary breast cancer. It's an autosomal dominant pattern, and it markedly increases the chances of developing breast cancer as well as other cancers. In people with who screen positive for BRCA1 or 2, they have a 60 to 70, up to 60 or 70% lifetime risk of developing breast cancer at age of 70, compared to 9% in general population. And for those who develop breast cancer, they have a 63% increase at 25 years in developing breast cancer in the contralateral breast, compared to 10% in the general population. For around 5% of all breast cancer have mutation in BRCA2, 1 or 2. And if we look at the hormone positive HER2 negative breast cancer, it's around 10% and up to 20% in triple negative breast cancer. And as you can see in the pie chart here, there are many mutations. Most are still not actionable or targetable, but the BRCA1 and 2 remains the take most of the mutations. These are trials that have tried to look at our statistics in the Middle East. Just to eyeball it, I'll not go into details. There was some variability in prevalence from around in BRCA in our area around between 5 to 20%. And this is mostly because of the study design or inclusion criteria or different demographics. Some trials have included VUS in the criteria. Just to know about that, there have been some effort done here. So who should get tested for BRCA? If we look at the NCCN guideline, if you go and read into it, you'll start asking yourself who should not get tested for BRCA, because now the criteria is getting wider and wider. And basically what they did is they put them in two distinct groups of patients. The patient who have a strong family history or a family history of BRCA, and we do the test for screening and prevention. But now we have a different group that fulfill the PARP inhibitor treatment criteria. And if we read here in the NCCN guideline, it says it's to aid the systemic treatment decision using PARP inhibitor either in metastatic or adjuvant setting, and they left it open for us to decide who will benefit from this treatment. PARP inhibitor encodes for the enzymes that help maintain DNA integrity during replication and repair in single-stranded DNA break. They have a synthetic lethality in cells deficient in homologous recombinant repairs, such as those in BRCA1 and 2. And PARP inhibitor have demonstrated efficacy in BRCA mutated cancer, including breast cancer. So the PARP inhibitor in metastatic breast cancer, this is the Olympia D trial, which was presented in ASCO 2017. It's the first trial to approve the use of PARP inhibitor in metastatic breast cancer. And Olympia D is a phase 3 trial investigating olaparib versus chemotherapy in germline BRCA HER2-negative metastatic breast cancer. Inclusion criteria were included triple-negative breast cancer or HER2-negative hormonal positive breast cancer who received 2 or less lines of chemotherapy. They were randomized into receiving olaparib or chemotherapy. The primary endpoint was PFS. Overall survival was part of secondary endpoint. And the patient characteristics were balanced between two groups, and 50% of them were ER positive, and the other 50 was triple negative. And I just want to point out that this is kind of a heterogeneous study because it included patients who did not receive chemotherapy and patients who received chemotherapy prior to treatment, and around 1/3 of patients had not received chemotherapy in both arms. So it met its primary endpoint with progression-free survival, adding 3 months into progression-free survival with hazard ratio of 0.58. Similar thing in progression-free survival 2. However, overall survival was not met in this study. It was almost identical between both groups with hazard ratio of 0.9. Again, I mentioned that this is a heterogeneous kind of study, and when they did a subgroup analysis looking into those patients who did not receive chemotherapy versus who did receive chemotherapy, they found that the patient who did not receive chemotherapy, they took olaparib in the first line, they did significantly better in this. The overall survival was different with a significant hazard ratio of 0.55. And the median overall survival was 22 months in those patients compared to chemotherapy. And for those patients who did take chemotherapy, this benefit was lost. So that's why when we look in the NCCN guideline, You'll see that the preferred option for those with germline BRCA mutation is to start with olaparib or talazoparib, and you'll see in the footnote that it can be used later in the different lines, but evidence suggests that we use it in the earlier settings. Objective response was higher with olaparib compared to chemotherapy, and the median time to respond was almost identical in both chemotherapy and olaparib, which kind of debunked the myth that, you know, if you have a visceral crisis, just go to chemo. This is thought-provoking, you know, that other drugs can be used apart from chemotherapy. The reduction in the risk progression was seen across all pre-specified groups. And also when patients with inactive brain metastases, endpoints were consistent with overall population. Another trial, the IMBRACA trial, which came right after the Olympia D trial, looking into talazoparib versus chemotherapy in advanced BRCA1 and 2 positive HER2 negative breast cancer. Again, similar population, however, received 3 or less lines of chemotherapy before randomized into talazoparib or chemotherapy, and the primary endpoint was PFS. Secondary endpoint was overall response and overall survival. Again, it met its primary endpoint with a hazard ratio of 0.54. And similar thing also in the pre-specified subgroups, also with those with inactive brain metastases as well. This is just out of comparison between both studies. Both added 3 months of PFS to those patients compared to chemotherapy, so there was significant increase in PFS, also quality of life, however, no improvement in overall survival. This is the tolerance profile of olaparib. Just be aware of hematological side effects and nausea. And I just want to point out that alopecia was higher in the talazoparib arm with 25% compared to 3% in the olaparib arm, which is kind of important when you deal with disease that is predominantly by female. Another interesting study is the PROCADE-3 study, which looked into vilaparib combined with chemotherapy. Now, vilaparib is not the most potent PARP inhibitor. However, it's safer to be combined with chemotherapy. And they looked into vilaparib in the similar patient population with chemotherapy versus placebo, and primary endpoint was PFS. And it met its primary endpoint, adding 2 months to those patients, the median PFS, with a hazard ratio of 0.69. This drug is not in commercial use, and it's not FDA approved. Remember that olaparib have been studied in patients other than BRCA, germline BRCA mutation, and other targets, and even in general population with no targets. This is one of the most recent studies. I looked at it because it was presented in San Antonio 2 months ago, which is called KeyLink, pembrolizumab plus olaparib versus pembrolizumab plus chemotherapy, after induction with pembro and chemo for locally or recurrent inoperable metastatic triple-negative breast cancer. So the idea was that in preclinical model, PARP inhibitor activated the STING pathway, which upregulates the PD-L1 expression, which might lead to more synergistic effect when combined with anti-PD-L1 therapy. So the inclusion criteria was those with locally advanced or recurrent metastatic triple-negative breast cancer, regardless of BRCA mutation status. It was just stratified afterward in the randomization. Those patients received chemotherapy plus immunotherapy induction, and those who had stable or responsive disease were randomized either to receiving olaparib plus pembro or to continue with chemo plus pembro. And it was well balanced between 2 groups. The BRCA mutation, just want to point out that BRCA were only 20% of those patient population. And the PFS was not improved in the olaparib arm compared to chemotherapy arm with a hazard ratio of 0.98. Similar thing with the overall survival. And in the first part, we'll see that it's almost identical, but you know, in the BRCA mutation, there was a numerical trend toward improvement in PFS and overall survival in the BRCA mutated patient. In terms of adverse events, the treatment-related adverse events were higher in the chemotherapy plus pembrolizumab arm compared to olaparib arm when it comes to almost all adverse events. And when it comes to immune-mediated adverse event, it was almost similar between both arms. There was more infusion reaction seen in the chemotherapy arm. So my last talk, it was already mentioned nicely by Dr. Mishari. It's about the Olympia A, the adjuvant olaparib for germline BRCA1 and 2 mutated early breast cancer. So this trial included patients with pathogenic BRCA1 and 2 mutation, stage 2 or 3, and they stratified them according to risk. I'm not going to go into detail how they stratified them, but just know that those patients who were deemed as high risk were randomized into receiving olaparib versus placebo, and the primary endpoint was IDFS and invasive disease-free survival, and secondary endpoint was distant disease-free survival and overall survival. This is the high risk criteria they used. It's not restrictive. However, this is just to guide them in the trial. It was well balanced between both groups, and all patients have had neoadjuvant or adjuvant chemotherapy. And just to point out that that triple negative group was consistent around 80% of those population, and that the ER or hormonal positive group, they were included late in this trial. So it met its overall survival with benefit of 90% in patient at 4 years, with hazard ratio of 0.68 and absolute difference of 3.4. This was seen almost in all specified subgroup. Again, the hormonal receptor positive patient, they were included late in the trial, so we have to wait and see how this plays out. In terms of invasive disease-free survival, it also met its primary endpoint with hazard ratio of 0.58 and absolute difference of 8.8. This difference was held after in the second interim analysis with a difference of 7.3. And the frequency of each type of invasive disease event was lower with olaparib arm compared to the placebo, including the distant recurrence, CNS recurrence. I just want to point out the second primary malignancy, which the numbers were small and it's too early to judge, but there is an intriguing figure here where you see that half of patients on olaparib arm developed second primary malignancy, which kind of triggers the question: will we see a PARP inhibitor used as a prophylaxis measures at one point? Distant disease-free survival was also met with hazard ratio of 0.61. And these are the adverse event profile. There was no increase in the adverse event of special interest. And I just want to point out that there was more permanent discontinuation, around 10% in this study compared to in the metastatic setting. And that's just to put things in perspective. There was 10% discontinuation compared to between 5 and 6% in the Olympia D and in BRCA arm, and 16% in the abemaciclib arm. So this is the safety profile. It was consistent with previous studies of olaparib. So my conclusion is germline testing has a therapeutic implication in early and advanced breast cancer. Olaparib improved overall survival in patients with germline pathogenic variant BRCA with high risk HER2 negative early breast cancer. Olaparib and talazoparib are preferred treatment in patients with germline pathogenic variant with BRCA1 and 2 with ABC, and olaparib may be considered advanced breast cancer, and olaparib may be used in germline PALB2 mutation and somatic BRCA1 and 2 mutation. We need to ensure the timely access to accessible genetic testing to ensure timely access to PARP inhibitor in early and advanced settings. Thank you.
Thank you, Dr. Osama. I would like to invite our speakers, Dr. Osama and Dr. Mshari. يعطيكم العافية. We heard 3 topics about triple negative early and metastatic and then the mutated. I would like to ask the audience if you have any questions. تفضل دكتور ماجد.
Thank you for all the speakers for this excellent presentations. My question is to Dr. Osama Halawa regarding the cross-resistance for ADC after ADC. Any concern regarding that? We know that we don't have data, but are you comfortable to use ADC after one after another?
I would say no. I'm not comfortable with this because of lack of evidence, number one, and because the payload is the same with the current 2 approved antibodies. So it depends on the mechanism of the resistant. If it is resistant to the payload, so you are wasting money and wasting time, precious time for the patient. But if it has to do with the receptor or the linker, then it might work. But honestly, I think it's a evidence-free area, and the answer will be I would not sequence these 2 antibodies.
If I may add, Osama, I would give chemotherapy in between. I know that there is no data about that, but it seems like it's a reasonable choice, first of all, because the data that we have currently is that ADC after ADC, the overall response rate goes down from, let's say, 60% to less than 10%. So a chemotherapy may correct the balance, and it seems like a reasonable choice to me. I don't know with you.
If you have to do it, do it Ahmed way, which is don't give them immediately after each other. And the same thing applies for HER2 positive. People try to space with the TKI chemotherapy and then go back to the TDM1 or Enhertu. But again, it's especially in triple negative, it's evidence-free area.
So I have a question to Dr. Mshari regarding continuation of Bimbro for early triple negative after PCR. So what's your practice in King Faisal?
Yeah, actually we didn't offer pembrolizumab for patients who achieved complete pathological response. However, in the last update in San Antonio 2 months ago, it seems like there is additional benefit from continuing pembrolizumab, but the question here, is it the benefit from post-operative pembrolizumab or pre-operative? Because we have other trials that showed addition of adjuvant immunotherapy doesn't add much. There is ongoing trial, as I presented in the slides. Simply, it will answer the questions, but for now, we don't use it.
It was the same question, but actually for all of you, when you get to Atezo data, which is complete failure, I mean, it's out of the question. Now we get Dorva, it's promising. Bimbo, I don't know how they designed the trial to be positive, but it's positive. So immunotherapy in triple negative breast cancer is really, even the overall survival is not that impressive compared with other malignancies. So what the difference between Dorva to get impressive, we're still waiting for final, and Atezo, which is negative. I mean, Dorva and Atezo are both BDL1 inhibitors. We may argue that BD1 inhibitor is probably superior to BDL1 inhibitor. That's my thought. I may be wrong. But why we see like, variation in the outcome when you use different immunotherapies?
Maybe it's difference in the study design or population, but I don't have an answer for that.
I don't think, I agree with Dr. Mshari, it has to do with the study design population. I don't think anti-PD1 versus anti-PDL1 as we stand today make any difference. Because some are PD1 inhibitors, some are PDL1 inhibitors.
These medications are completely different. We saw them in lung cancer where nivolumab and pembrolizumab, they have performed completely different. For instance, for PD-L1 over 50%. So it seems like there is in fact, when I was a budding thoracic oncologist, I asked that question WCLC to one of the authorities, and it seems like there is a difference in the affinity of these medications to the cancer tissue or the tumor tissue. So, but definitely they are not interchangeable, and it has to do with the molecule, not necessarily with the study design, in my opinion.
Question to Dr. Osama Abdul Jalil regarding the PARP inhibitor in the first line. I mean, in the trial, they are those patients not chemo naive. I mean, not naive. Just being treated with neoadjuvant, adjuvant, then given first line. So regarding the patient who was naive, upfront metastatic, what is the rationale to put PARP inhibitor as a first line?
So these patients were mostly hormonal, also positive, and they progressed on hormonal therapy. So they were allowed to go into olaparib, to receiving olaparib prior to receiving any chemotherapy prior. So in this subset of patients, there was an improvement in overall survival compared to those who received it in the second or third line setting. So that's why you'll see that now olaparib seems to have a better efficacy when it's pushed earlier in the treatment of those patients.
I mean, in the metastatic first line, metastatic triple negative.
Yeah.
So in the NCCN, they put it in the first line PARP inhibitor. I mean, and you showed that there is a subgroup for patient who was, the first line or did not receive any prior line. It showed some difference in the survival. But those patients had previous neoadjuvant adjuvant. So my question about the upfront metastatic patient, upfront metastatic, triple negative, and BRCA mutant. What is the rationale to give them PARP inhibitor in the first line? I mean, for the NCCN to put it in the first line.
So this, as per trial, again, some of them have recurred. I'm not sure about the recurrence time, if it was more than 6 months or not. Maybe this will explain some of it. Again, we've seen the time to response. We've seen the objective response rate and the overall survival. So these all, lead us toward better numbers and a better outcome in terms of when the PARP is used the earlier setting.
Any more questions? Okay. Thank you so much. Thank you for our speaker. And thank you for Dr. Ahmed for arranging this such a good meeting. Thank you so much. We're going to a break. We'll see you here back at 10:30.
company. The topic that we are going to discuss in the next 30 minutes is really very important. It's about ever-changing algorithm treatment in ER-positive, hormone receptor positive breast cancer in advanced stage. As of 2023, 2024, we have a very distinct treatment algorithm in endocrine sensitive treatment algorithm and endocrine resistant treatment algorithm. In the endocrine sensitive treatment algorithm, we have an established first line treatment. However, the subsequent lines of treatment, there is a lot of controversy. There is a lot of good and excellent lines of treatment. Which one is better? Which is the best sequence to have for your patient to sequence upon progression is really a yet to answer question. So today we are going to discuss all of that. I'm glad to introduce my colleague and friend, Dr. Ihab Hassan. He is a consultant medical oncologist, King Fahd Specialist Hospital in Dammam. He'll talk to us about treatment algorithm and management beyond the first line CDK4/6 inhibitor in ER-positive breast cancer. Dr. Ihab.
Assalamu alaikum. Thank you, Dr. Abdurrahman, for your kind introduction. I'd like to thank my dear friend, Dr. Wabari, for his kind invitation, and thanks for Minerini for sponsoring this activity. So the story is very clear for maybe HER2-positive breast cancer, but for the luminal breast cancer, the story is much more complicated post-CD4/6 inhibition. Here is my disclosure, and this is the outline of my presentation. We start by talking about some introduction, ESR mutations, and what do we have evidence for the selective estrogen receptor degraders, and then I will conclude. As early as 1882, Thomas William suggested that the breast cancer is a hormone-dependent disease when he noticed that cancer breast regress after menopause. And in 1896 also, the father of endocrine ablation started ovarian ablation for patients with breast cancer. So this diagram just shows the source of estrogen in premenopausal and postmenopausal women. In premenopausal, it's under the control of the hypophyseal gonadal axis, and the source of post-menopausal estrogen mainly from adipose tissue and adrenal gland with the peripheral conversion of androstenedione to estradiol with aromatase enzyme. So this is the various sites of blockade on the receptor level and on other levels. So endocrine therapy is the standard initial treatment for patients with metastatic breast cancer that are hormone receptor positive and HER2 negative. Endocrine therapy include drugs that act by inhibiting the estrogen production and agents that modulate the estrogen receptor directly in cancer cells. Estrogen production can be inhibited by gonadotropin-releasing hormone agonists and by aromatase inhibitors. Selective estrogen receptor modulators include tamoxifen and torimifene. The ER antagonist fulvestrant acts by selective degradation, selectively degrading the ER in the cancer cell. Moreover, we have the CD4/6 inhibitors, we have everolimus, we have alpelisib, and they are used in addition to endocrine therapy. As early as 2002, fulvestrant was the first approved selective estrogen receptor degrader. And the problem, it's used in a single agent, and then the dose level was 500 and was given IM, and unfortunately it blocks only 50% of the receptor. Also, it was combined with, of course, with the CD46 inhibitor. So more recently, we have the phase 3 clinical trial showed prolonged PFS with addition of alpelisib to fulvestrant for patients who harbor the PIK3CA mutation. So in first line, the story is very clear. So we have the different trials for the CD46 inhibitors, improvement in the PFS ranging from 20 to almost 34 months. So what do we have post CD4? We have the SOLAR-1 trial of alpelisib with fulvestrant for patients with the PIK3CA mutation, and Polaro-2, everolimus, and exemestane. What about the ESR mutation? ESR mutations are mutations that it constitutes about 20 to 40% of metastatic breast cancer patients who are treated with aromatase inhibitors, and it drops to less than maybe 7% after neoadjuvant, and in patients who are not treated with endocrine therapy drops to less than 1%. The prognosis for patients with ESR mutation is more worse for those who don't harbor the mutation. And this is the testing recommendation. Patients whose tumor or circulating tumor DNA test remain ESR wild type may warrant retesting, and the ASCO guidelines recommend testing at recurrence or progression on endocrine therapy, either with or without CD46 inhibitors. So it's a liquid biopsy, and ESMO recommends testing circulating tumor DNA, ASCO blood-based ctDNA. The BEDA-1 trial used the ddPCR, and the NCCN recommends NGS or PCR in the blood. So fulvestrant partially inhibit the mutant estrogen receptor alpha, and clinical use dose is 500, and this is a quite smaller dose which blocks only 50% of the receptor, and much higher doses still needed for downregulation of the mutant ESR1 function. So this is the genomic mutation in different type of trials for the ESR mutation, ranging from 26 up to 48% in the recent Emerald trial. So mutations in the estrogen receptor gene alpha, which encodes the ER, have been associated with resistance to aromatase inhibitors in patients with advanced luminal breast cancer. And the occurrence of resistance to currently approved endocrine therapy agents and the fact that fulvestrant requires intramuscular injection have led to an interest in newer agents with better bioavailability and more convenient way of administration. The elacestrant is an oral non-steroidal small molecule SERD that selectively binds to estrogen receptor and activates its degradation. In the next couple of slides, we'll be talking about elacestrant as a member of selective estrogen receptor degraders. Different trials use different molecules. Some are negative, and only 2 trials are positive. We'll be concentrating on the Emerald trial using elacestrant phase 3 trial. So also SERDs are used in the adjuvant setting, alone or in combination with CD46 inhibitors. Those trials are still ongoing. And this is the design for the Emerald trial. It's a phase 3 randomized open label trial, recruited men and postmenopausal women with ER positive HER2 negative metastatic breast cancer, who relapsed or had progressive disease after 1 to 2 lines of endocrine therapy, and 1 line is obligatory by the study design to be the first line CD46 inhibitor, less than 1 line of chemotherapy for advanced disease. They randomized patients, recruited almost 500 patients, randomized to elacestrant 500 milligram QD versus standard of care. This was given until disease progression or unacceptable toxicity. Primary endpoint PFS for all patients, PFS for patients with ESR mutation, and key secondary endpoints, the overall survival. This is the baseline characteristics. Just of note that almost 70% of patients had visceral metastasis across the whole groups, and as per requirement, 100% of patients received prior CD4/6 inhibitors, and the treatment of physician choice, 80% of patients received aromatase inhibitors. So this is the primary endpoint, PFS, with elacestrant versus physician choice, showing that there 30% reduction of progression or death, hazard ratio 0.7, and for patients with ESR mutation, the magnitude of benefit was much higher, 45% reduction in progression, the risk of progression or death, and the hazard ratio 0.55. This is just subgroup analysis according to the duration of CD4/6 inhibitors, 6 months, more than 12 months, and at 18 months, showing that the response is more profound for those patients who received CD4/6 inhibitors beyond 12 months. So FDA approved elacestrant for treatment of postmenopausal women or adult men with ER positive, HER2 negative, ESR mutated advanced or metastatic breast cancer who had disease progression following at least one line of endocrine therapy. This is the subgroup analysis showing that all the subgroups did benefit from elacestrant. Only the Asian subgroup, maybe they are crossing to the other side, but apart from this, all the groups did benefit. What about the adverse events? Almost the adverse events were grade 1 and 2, and the majority was in the form of GI toxicity, nausea, vomiting, decreased appetite, and diarrhea. So no safety issues. Most adverse, as we mentioned, grade 1 and 2, no grade 4 treatment-related adverse events. Quality of life was maintained between the treatment groups. No hematological safety signal was observed, and no death assessed at treatment-related were reported. So we have some updates for the Emerald trial from last San Antonio. Actually, they had subgroup analysis for those patients, ESR mutation and having bone metastasis, ESR mutation and having liver and or lung. What about if the patient is having ESR mutation and PIK3CA mutation, and then patients with the HER2 low and patients with the TP53 mutations. So all those subgroup analysis for patients who received CD4/6 inhibitors more than 1 year. So the PFS was maintained for those patients who had ESR mutation and bone metastasis, also for those with liver and or lung metastasis, also for patients who are having the PIK3A mutation or not, and also for HER2 low expression or having HER2 zero expression. Again, having the TP53 mutant or wild type. So this is the median BFS for all subgroups in the last update. Of mention here that patients who had the worst PFS in the range of 5 months, as you can see here, number 3, the patients who are harboring the ESR mutation and having the PIK3CA mutation, and was highest for patients who have ESR mutation and bone metastasis, which is quite logical. So what other types of additional endocrine therapy? We have the BROTACs. BROTACs are proteolysis targeting chimers. One drug tried VB-Gistrant, tried in phase 1, phase 2, and then tried in phase 3 study, combined also with palbociclib. So the VERITAC-2, this is phase 3 trial, of the new molecule versus fulvestrant after progression on CD4/6 inhibitor plus endocrine therapy. What about other SERMs? Those are the selective estrogen receptor modulators, tamoxifen and bazidoxifin. We have a recent molecule, the lasofoxifene, which is being tried with abemaciclib, and it showed a median BFS of almost 56 weeks with good responses. Another group of drugs, the CERAN are complete ER antagonists, so this might just overcome the problem of incomplete ER antagonist with other molecules. We have the balazistrant tried in phase 1/2 trial and showed good responses, median PFS on overall 38. We have also very important trial post CD4/6 inhibition, the BEDA-1 trial. The study design of this trial, that those patients who are luminal breast cancer and on bulbo and aromatase inhibitors, so they are we do serial testing for the ESR mutation, and those patients actually, they don't have progressive disease, they are still on this medication, and those patients with rising ESR mutation were randomized to either to continue to the same medication, or we replaced the aromatase inhibitor with fulvestrant. And the primary endpoint was the PFS and the intention to treat. So this is the BEDA-1 PFS, 7 months difference in the switch, in favor of the switch to fulvestrant, hazard ratio 0.54. This is the PFS2, almost doubling difference 14 months, and hazard ratio 0.37. So what's the current approach to newly diagnosed hormone receptor positive HER2 negative breast cancer? We have tumor biopsy, first line. Most of the patients will receive endocrine therapy and CD4/6 inhibitors. If they have intermediate progression, we go for a liquid biopsy, and we might consider endocrine switch from AI to fulvestrant, like in the BEDA-1 trial. If they are having definite progressions, nowadays maybe options are expanding. We do a liquid biopsy, and we'll go for second line. If they harbor the PIK3CA mutation, we might go for fulvestrant alpelisib. If they harbor the ESR mutation, elacestrant. If they are BRCA mutant, BARB inhibitors. No mutations, so we might go for the fulvestrant plus or minus everolimus, or exemestane everolimus, CD4/6 switch. And of course, with the recent data from chemotherapy or ADC. Based on the Emerald trial, ESMO guidelines incorporated the elacestrant in the guidelines in second line, and also in NCCN guidelines, the version 2.2023. In conclusion, mutation testing is key to treatment decisions for patients progressing of first-line endocrine therapy with or without CD4/6 inhibitors. Better assays to define the ER resistance are needed to identify appropriate patients for further endocrine therapy. Single-agent elacestrant is approved for those with clinical benefit on prior CD4/6 inhibitors who harbor the ESR1 mutation, and other oral SERDs are on the horizon. How to target agents will be combined with oral SERDs remain to be determined. Elacestrant was the first oral SERD to improve PFS in previously treated patients with hormone receptor positive HER2 negative advanced breast cancer when compared to standard of care endocrine therapy. Importantly, it was more beneficial in patients ESR mutation, which is a known mechanism of resistance to aromatase inhibitor, and this was, led to FDA approval for this patient subpopulation. And there's ongoing clinical trials evaluating elacestrant and other SERDs, which will provide data that may assist clinicians to decide what's the best choice and sequencing of endocrine therapy agents for patients with luminal breast cancer. Thank you.
Thank you so much, Dr. Ihab. It was wonderful, very comprehensive. Do you have any questions for treatment beyond CDK4/6 inhibitor? Any questions? Okay, so I'll ask you a question, Dr. Ihab. And this is a practical question. Actually, you put it in one of the last slides. So what's your approach for a patient who is postmenopausal, with de novo stage 4 disease, with bone-only disease, who started on CDK4/6 inhibitor and backbone of endocrine therapy, let's say Remedix, okay? And after 2 years on treatment, you did her scan, restaging scan, reassessment scan, and you found a new liver lesion that was not there before, okay? The patient performance status is okay. She is asymptomatic. What you would do for this patient? And this is a common scenario.
Yes, we are facing quite common this in the clinic. So recently introduced, you might go for the ESR mutation, and we will go for the PIK3CA mutations just to see what's going on. And then according to the result, we might start dealing according to the result of the mutation. Actually, it's very difficult to decide because there is a subgroup of patients who are harboring both medications. So no trials just combine both. So which one you will go first? This will be the question. Still, it's not answered, but I think it will be according to the availability of the drug, maybe.
Yeah. So it's a difficult question to answer, actually, but sometimes you will be guided by some kind of molecular alteration that you discover to the patient. So you put there possible biopsy, liquid biopsy, maybe tissue biopsy, whatever to help you to decide what's next. Any other, Dr. Enter?
Thank you for this excellent presentation. My question based on the PADA trial you present, so is this the standard of care now to test ESR regularly once a patient on AI and CDK inhibitor?
We are doing this actually. We are doing this, but I don't think it's formalized to be a routine practice. A routine practice, you do ESR mutation as part of maybe the genomic profiling, but I don't think it's a routine practice to measure the serial ESR and then you shift. At least this is what we are practicing in our center.
Just a quick comment on co-mutation of ESR1 mutation and PIK3CA alteration. It seems like for instance, if you use the AKT pathway, اللي هو capivasertib, even if you have ESR1 mutation, it works.
It works. Yes.
But we don't know the opposite, if it's quite effective or not. So certainly, as we discussed, Abdurrahman, if we go through the scenario of ER sensitivity, more than 12 months of CDK4/6 inhibitors, and with no fulvestrant used in the past, and ESR1 mutation, I think I'll be comfortable with using elacestrant. But if the patient is more resistant, and there's PIK3CA or alteration in it.
Yeah. One comment just for your question. What I feel is that the measuring of serial ESR mutation, it looks like something like of academic interest. And the practice is you measure it, you have the ESR mutation, you go for the drug. But I think it's this is my explanation, academic interest.
Last question with Dr. Abdel Nasser.
Just this trial excluded premenopausal, my understanding. And why male patients is more ESR1 mutation, male patient than female? And why premenopausal were excluded?
I don't have a explanation, but premenopausal and other trials, some trials excluded the premenopausal women, but I'm not sure if you have a premenopausal woman, you need to apply the trial. It was not, it didn't include the premenopausal.
Just the chance to have ASR1 mutations less or something?
I don't think so. I think the chance will be the same if you use.
Probably they start with postmenopausal and then later maybe will encompass.
Maybe, but they are totally excluded.
Okay, thank you so much, everyone. Thank you. Thank you, Dr. Ihab.
Yalla, hold your breath. This is the last session for today. So I would like to call the moderators for next session, Dr. Muhammad Al-Amir, Dr. Abd Nasser Nurallah, Ala Salman, and Dr. Ali Al-Jabran. So, anybody? Dr. Ali, this is the most senior.
Thank you so much.
Speakers.
Assalamu alaikum. I would like to thank Dr. Ahmed Al-Wabari and Moosa group for this successful scientific meeting. Now it's my pleasure to introduce our next speaker, Dr. Mustafa Al-Mubarak. Dr. Mustafa Al-Mubarak is well-known medical oncology at King Saud Medical City. In the next 20 minutes, he will speak about low HER2 updates. So welcome.
Assalamu alaikum. Thank you very much. I'd like to thank Dr. Ahmed Wabari and Moosa group for this successful meeting. And Bismillah ar-Rahman ar-Rahim. My talk will be about HER2 low, what's new. It's kind of been mentioned in this meeting, and I'll try to concentrate on different points that was not mentioned in the previous presentation. So this is the outline of my talk. First, I'll give some introduction about HER2, and then therapeutic options for the HER2 low and guideline, and then ongoing trials for HER2 low. So what is HER2? HER2 is one of the epidermal growth factor receptor family, which is HER2-1, HER2-2, 3, and 4. And this receptor, when stimulated, it will bind together either hetero or heterodimerization and lead to signaling and growth of the cells. The HER2 is expressed or present physiologically in all cells in the body. So it's present in the breast, as well in the GI, gynae tissue as well. So, and there are drugs even used, anti-HER2 used in different cancer, not only in the breast cancer. Recently, FDA is discussing approval for the trastuzumab deruxtecan for HER2-expressing cancer as a second line, regardless of the origin of the tumor. So also it's expressed in the heart. That's why one of the side effects of the anti-HER2 is led to drop in the ejection fraction as well heart failure. So the HER2 expression been discovered in around late 80s that breast cancer with HER2 expression is of negative prognostic impact. And it takes around a decade, and this led to division of the breast cancer to be HER2 negative and HER2 positive, as well ER positive. This is the classic division in the past, still used in the early stage, but in the metastatic system, as we will show, it became different. And then discovery of trastuzumab that target the HER2, which led to efficacy. And nowadays there are 8 anti-HER2 used in early stage in HER2 positive breast cancer, either in early stage or in metastatic setting. And the testing for HER2 is, until now, this is the CAB ASCO guideline. They did not include HER2 low yet in their division. And the HER2 testing is either based on the immunohistochemistry, and if it is +2 and the immunohistochemistry, then you have to do the FISH or the in situ hybridization, and then the HER2 positivity based will be defined. This is just a picture or slide just to show in the right lower side of your side, you could see the +3, the HER2 expression, and classically it used to be named as pathway active, and +1 and +2 is pathway not active, and 0, of course, it's non-active. Then the question in the past been answered, but now it's changed. Can we give anti-HER2 for HER2 negative? The answer is no in the past, and there were trials about usage of trastuzumab in the HER2 negative in the early stage, and absolutely showed that there is no benefit. As well, there are, and this no benefit seen in different subgroup, and also there were work about pertuzumab to be used in the HER2 low or HER2 negative as well. It did not show any benefit. The same things for TDM1. So the HER2 low, it's a new entity now defining the HER2 testing by immunohistochemistry, either +1 or +2, that is FISH negative, and the interest or the interest to show that there is some benefit from this, the anti-HER2 for the HER2 low, came from earlier trial or early phase trial. So this trial that was published in 2016, usage of TDXD in vivo study, as you could see here in the slide in the picture. The brown color is the HER2 positive. The light blue is HER2 negative. When they give these in vivo cells TDM1, there was the HER2 positive cells disappeared or died, and then there will be remaining HER2 negative cells. And when they give them TDXD or trastuzumab deruxtecan, there was tumor regression, and some even of the HER2 negative cells disappeared. So this led to this explained by that the TDXD has high affinity to the cells and different mechanism of action than trastuzumab, and it has the advantage of bystander effect, and it's been mentioned in this meeting many times. And also that the reason is why the trastuzumab deruxtecan work better than TDM1 is explained in this table, also mentioned in this meeting many times. It has different chemotherapy attached to the trastuzumab, which is topoisomerase 1, and more drug to antibody ratio in the TDXD, and different in the selective linker, as well in the bystander effect. So the early phase trial, phase 1 trial, showed that there was efficacy to use trastuzumab deruxtecan in the metastatic setting, and the overall response rate in this phase 1 trial showed it reached to 37%, and median BFS 11 months, and this did not differ between +1 or +2. Additional drug, which is targeting HER2 in the HER2 setting in the early phase trial, also showed that there was some benefit. So trastuzumab, docarmazine, as well DCTMab, these drugs still in development, both tested in HER2 low and showed that there are some responses. So this led to a phase 3 trial. This is the Destiny-04 trial. So this has been mentioned in this meeting many times. I'll just concentrate on different points in this trial. So in this trial, it's a randomized phase 3 trial, and patient randomized 2:1 to TDXD versus treatment of physician choice, metastatic breast cancer, HER2 low, which is +1 or +2 FISH negative. Patient has to receive 1 or 2 line of the chemotherapy, and for hormone receptor positive disease, it has to be endocrine refractory, And in this trial, they did not really define clearly what is endocrine refractory, but they left it for the physician discretion to define or to tell whose patient is endocrine refractory. They included most of the, 90% of included patient in this trial is hormone receptor positive, and only 10% hormone receptor negative, triple negative HER2 low, only 60 patients. And the primary endpoint was kind of different. BFS for HER2, for hormone receptor positive, the primary endpoint, and the key secondary endpoint, BFS for all patients, and OS for hormone receptor positive as well in all patients. It's kind of that the drug company, maybe they were not sure that this drug will work in HER2 and the hormone receptor negative, that's why they included low number of triple negative HER2 low. Just see here, this is the treatment disposition. Just concentrate on the chemotherapy here. They used different chemotherapy, eribulin, capecitabine, nab-paclitaxel, gemcitabine, paclitaxel, compared to the trastuzumab deruxtecan, and we'll come to this later on. As I mentioned, 90% of included patient is hormone receptor positive. They included patient with brain mets with stable, as well patient with visceral metastasis, lung or liver metastasis, and balanced number of +1 and +2. Also balanced number about patient who is getting the first line, second line therapy, as well first line, second line chemotherapy. And around 65% of included patients in this trial received CDK4/6 inhibitor. This is the result of this trial being presented in ASCO 2022, updated last ESMO. It showed that there is progression-free survival benefit of trastuzumab deruxtecan compared to the physician choice. The progression-free survival improved from 5.4 to 10 months, with delta, absolute difference 4.7 months. In the primary endpoint, which is hormone receptor positive, as well in the all patient. And in the subgroup analysis, this benefit seen in all subgroup, regardless if it is they received prior CDK4/6 or not, and +1 or 2, and presence of visceral metastasis or not. This is the secondary endpoint about the survival, being presented again in ASCO 22 and updated, and same result updated in ESMO last year, showed that there is survival benefit of TDXD. It's the overall survival improved from 17.5 months to 24 months. In the hormone receptor positive, absolute difference of the survival 6.4 months, as well in the all patient. And this is presented in ASCO last year. The subgroup showed that the survival benefit was seen in different subgroup, and probably just concentrate in the prior line of chemotherapy. It seems that it's one of the stratification factor for this trial. It seems that the benefit of survival is probably more for those who received one line compared to those who received more than or equal to a line. And probably this is logical, because those patients will be, those who receive more than 2 lines, maybe they will have more resistant disease. This is exploratory endpoint. It's like a hypothesis generating, but some people, even the guideline, they apply usage of the TDXD in triple negative HER2 low, and all it's based on this exploratory graph, that there is benefit of progression-free survival as well overall survival of TDXD in the hormone receptor negative HER2 low, triple negative HER2 low. So there is a trend of survival as well, progression-free survival. Of course, because it's exploratory, they will not be able to give a p-value for this benefit. The overall response rate also improved with the TDXD and the hormone receptor positive as well in the hormone receptor negative. And just one point here, that the complete response for the triple negative HER2 low was slightly higher in the group who received chemotherapy, 5.6% compared to 2.5%. And also this waterfall plot just to show that there is higher response with the TDXD. This is the progression-free survival number 2, or the and post-study anti-cancer. It showed that there is also improvement of BFS2 with TDXD compared to a treatment physician choice. And if you could notice here that most of the subsequent therapy was chemotherapy and endocrine therapy. Very few patients received ADC, sacituzumab or TDXD in the post-progression. This is the side effect, drug-related side effect. It's kind of interesting. Just classic for TDXD showed the side effect: nausea, vomiting, high liver enzyme. But just check just see the chemotherapy, the side effect. So the 41% of patients had more than or equal grade 3 neutropenia. I mean, usually we don't do this in the palliative care setting to give chemotherapy to the extent to that the 40% in this trial achieved, had grade 3 neutropenia. So in this trial, they tried to give really heavy chemotherapy, and it's probably a positive point for TDXD that although they give heavy chemotherapy to the extent of 40% grade 3 neutropenia, now this drug the TDXD is better in terms of BFS as well overall survival benefit. So it's not a matter of strong therapy, it's a matter of smart or targeted therapy. This is just another table just to show the side effect. And the pneumonitis, any grade pneumonitis with TDXD, it's 12%. And 5 patients in this trial died due to pneumonitis. None or even just grade 1, 1 patient in the treatment physician choice developed pneumonitis. The drop in the ejection fraction as well, cardiac failure also, the any grade was 4% in the TDXD, none was grade 5, just 1 patient had grade 3. The treatment emergent side effect, just from this slide, just to concentrate on the treatment emergent adverse event that led to death. So it is 4% in the TDXD compared to 3% in the treatment physician of choice. So this drug has side effect, but I'm surprised that patient with treatment physician of choice, the treatment-related death reached to 3%. That's again just what I mentioned, that they use really heavy chemotherapy, and we usually don't do this in the palliative care setting, in the metastatic setting. So this established the HER2 low, which is again +1 or +2 FISH negative, and this is led to a new subdivision of breast cancer to be divided to HER2 low, HER2 positive, as well in the HER2 negative, and around 60% of hormone receptor positive is HER2 low, and triple negative, 40% of triple negative is HER2 low, it's estimated. And the TDXD approved in August 2022 to be used for patients who had prior chemotherapy in the metastatic setting, or for those who developed recurrence during or within 6 months of the completion of adjuvant chemotherapy. Also, this drug was approved in January 2023 in Europe, and it is now incorporated in the guideline. So in the guideline, in the second line setting, HER2 low, the recommended therapy is trastuzumab deruxtecan, preferred category 1. And for patient who is not candidate for trastuzumab deruxtecan, you could consider other therapy, including sacituzumab. In the triple negative, HER2 low, triple negative second line, The trastuzumab is here in the recommendation. Still, it is category 1 and preferred, one of the category 1 preferred. For patient who has no germline BRCA1 mutation and has HER2-low criteria, which is +1 or +2 FISH negative. So just brief about what is the future. This trial, which is an interesting trial, it will be, it's Destiny 06. This trial will test TDXD in chemo-naive patient, still hormone refractory. And here in this trial, they included around 150 patients with ultra-low. Ultra-low, they define it between 0 to less than +1, and it is randomization 1-to-1. This trial is expected to be presented this year. And if this trial came positive, then the definition of HER2 will be divided into HER2 positive, HER2 low, and then HER2 ultra low, and then HER2 null. Also, some work about usage of TDXD in the HER2 low. This phase 1 trial, it's kind of combination of the TDXD with hormonal therapy. Just presented in ESMO a few months ago. Part of the TDXD plus either anastrozole and fulvestrant in the metastatic setting, patient who received at least one prior line of hormonal therapy, no chemotherapy, and it showed that this is the side effect. It's like kind of interesting. There was pneumonitis with TDXD plus fulvestrant, and no pneumonitis of combination of anastrozole plus TDXD. And the response rate was slightly higher in the combination of anastrozole plus TDXD, 70 confirmed overall response, 71% compared to 40%. Also, additional work that is really interesting is to use TDXD for patients with CNS metastasis in HER2 low. So this is a DEBRA trial. It's a phase 2 trial. They included different cohort of patients, and some of these cohort included patients with HER2 low, like cohort 2 with patient asymptomatic untreated brain mets, cohort 4 patient with progressing brain mets, HER2 low, purely HER2 low, and cohort 5 HER2 low plus HER2 positive with leptomeningeal disease. And it showed that probably the response rate was lower for cohort 4, which is purely included patients with HER2 low compared to cohort 2. And what is more interesting is this leptomeningeal disease, which is really very poor prognosis disease, presented in the San Antonio a few months ago. This is just few number of patients in this phase 2 trial, 7 patients, but 57% of them HER2 low, and 42% HER2 positive, and it showed that TDXD led to median overall survival reaching to up to 13 months. It's really interesting. And leptomeningeal, usually the survival is just doesn't exceed in the 6 months, as well with some BFS benefit as well response rate. So with this, I end my talk. Thank you very much.
Okay, Dr. Mohammed Al Hassan from Al Jabr Oncology Center in Al Hassa will talk about immunotherapy and in hormone receptor positive breast CA.
Assalamu alaikum, and thank you for Al Moosa Health Group, and thank you for Dr. Ahmed for this invitation. So today I will talk about immunotherapy in ER positive early breast cancer. So these are my objective and nothing to be disclosed. And as we know that hormonal positive breast cancer is a heterogeneous disease, and it has better prognosis, but despite that some patients they have higher clinical features for which neoadjuvant chemotherapy is indicated. And as we have seen in triple negative in KNOT 522,
the improvement in BCR and event-free survival for pembrolizumab, and the question, would the story be repeated here in ER-positive patient? So this is first trial we'll talk about is Keynote 756, and they include patients with stage 2, stage 3 ER-positive, and they are all treatment-naive patients, and they randomized them to anthracycline taxane-based chemotherapy with or without pembrolizumab Q3 weeks, and all they went to surgery, and after that they received adjuvant pembrolizumab with endocrine therapy and plus minus radiation according to indication. And the study was powered for dual primary endpoint, which is PCR and event-free survival. And it is important to see here that there is some risk stratification, which include PDL status and nodal status and the level of ER expression. And we can see these the randomization arms, and the median follow-up was 33.2 months. So we can see that generally the patients were divided equally between two arms, and it is important to see that those patients who has BDL positive represent majority of patients, about 75% in both arms, and also we can see that they use dose-dense chemotherapy protocol and the Q3 weeks chemotherapy protocol. Also, we have to see, we can see that those patients who has lymph node positive represent the majority with 90%. Only 10% they have lymph node negative, and about 5% they have ER positive more than, 10 ER positive more than 10% represent 95% of population. And we can see this is the first interim analysis, and it showed that BCR was improved with 24% for pembrolizumab versus 15% for placebo with delta 8.5. Also here we can see the pathological complete response according to the stage of disease. We can see that there is no difference or much difference between stage 2 and stage 3 in terms of PCR rate, with delta 9% for stage 2 and 8% for stage 3 disease. This is also looking for PCR rate in patients with node negative, as we can see in that chart. Those who has lymph node negative had less clear PCR improvement for pembrolizumab in comparison to those who has lymph node positive, with delta 9 for lymph node positive and 3.8 for lymph node negative in PCR rate. This is according to geographic region. We can see Eastern Europe achieved much better PCR benefit to pembrolizumab with delta 13.3. Now this is an important slide. We can see those patients who has BDL negative, they achieve less benefit to pembrolizumab versus placebo, delta 4.5. But those patients who has BDL positive achieve greater response, and the higher the CBS expression, the greater the magnitude of PCR rate, and we can see the delta is 17.4. This is also another important slide. Let us start from that part of the slide. Those who has BDL negative and they have ER positive more than 10%, they achieve BCR improvement, but with less extent in comparison to those who has BDL positive with ER more than 10. They achieve much more BCR improvement to pembrolizumab with delta 9.4. Now, those patients who has ER positive less than 10%, we can see that those patients achieve much higher BCR improvement with 57% for pembrolizumab versus 33% for placebo with delta 24%. And it is important to see the number of patients. They are 19 versus 13. This is the residual cancer burden after definitive surgery, and we can see that pembrolizumab shifted more patients to PCR in comparison to placebo, with 35% for pembrolizumab versus 23% for placebo. And again, here, those patients who receive full chemotherapy protocol versus incomplete chemotherapy protocol, the improvement in PCR was regardless to that for pembrolizumab versus placebo. So this is what I already mentioned. We can see that those patients who has, lymph node positive achieved better response in comparison to those who has lymph node negative, and we can see that the improvement in BCR rate was regardless to tumor stage, and it is important to see that the BDL positive, the BCR rate was better in patients with BDL positive, and the higher CBS score, the better the BCR benefit. And again, we can see those patients with ER positive, CBS score more than 1, the benefit was for patient, the benefit of pembrolizumab was higher in patients with lower ER positivity. So this is the adverse event. There is no new safety signal, but it is important to do baseline TFT to monitor the patient, as because hypothyroidism is a common side effect. So in summary, addition of pembrolizumab to neoadjuvant chemotherapy led to statistically significant increase in BCR rate and intention to treat, and the addition of pembrolizumab increased BCR rate in subgroup patients defined by geography and the stage of disease, and the baseline lymph node involvement, and the different level of BDL expression. Larger magnitude of PCR benefit was observed in patients with node positive and higher BDL CBS threshold and lower ER expression. And the patient who received less than planned chemotherapy doses has lower BCR rate, although BCR rate was improved in both group regardless of the chemotherapy exposure. Addition of pembrolizumab to neoadjuvant chemotherapy shifted more patients toward lower residual cancer burden category 0 to 1, and there is no new safety signal. But the important here is that this study was powered for a dual primary endpoint, which is event-free survival, and the data here is immature, so we need to wait for further follow-up to see. The second trial is quite similar in eligibility. Those patients with stage 2-3 disease, but here the agent is different, which is nivolumab added in the neoadjuvant with anthracycline taxane-based chemotherapy versus placebo, then continued in the adjuvant setting. And the primary endpoint is BCR rate. So this was presented in ESMO. The BCR rate was improved with 24% for nivolumab versus 13% for placebo, with delta 10.5 for intention to treat. And we can see here those patients who has BDL positive achieve greater response in terms of BCR to nivolumab with 44% versus 20% with delta 24. Then there was an exploratory analysis presented in last San Antonio, and the aim of this exploratory analysis is to further define the patient who will achieve greater benefit to nivolumab in terms of PCR rate, and these are the biomarker that will be used in this analysis: CBS score and tumor infiltrating lymphocyte, and ER and BR and Ki-67. And we can see patients distributed equally between two arms, and we can see that the majority of patients, they are lymph node positive. So this is the prevalence of BDL positive decrease with BDL CBS assay value increase. And we can see that there is overlap between SB142, which is Ventana assay, and CBS assay in detection of BDL positivity ranging from 70 to 80%. And this is what we already mentioned, that there is improvement in BCR and intention to treat. And here, according to Ventana assay, there is improvement in BCR rate in those who has BDL1 or more with delta 24, as I mentioned. Now we can see that the higher the CBS score, the higher or the greater the magnitude of BCR rate, and to reach up to 78% versus 26 with delta 52. And again, the story is similar for residual cancer burden category 0 to 1. The higher the CBS score, the better the magnitude of BCR rate. And here, one of the biomarker is tumor infiltrating lymphocyte, and it was believed that this biomarker showed higher pathological response rate in HER2 positive and triple negative disease. And here, there is a concordance between Ventana and CBS assays and the tumor infiltrating lymphocyte in predicting the response reaching about 65 to 70%. And we can see addition of nivolumab in those who has tumor infiltrating lymphocyte more than 1% achieve better response in BCR rate versus placebo. And we can see that there is a cut-off line which is 3% or more and 5% or more or 10% or more for tumor infiltrating lymphocyte. And again, we can see the BCR rate is high, much higher in nivolumab arm versus placebo. This is an important slide, and we can see that those patients who has ER expression less than 10% achieve greater response to nivolumab versus placebo. And again, those who has ER expression of 50% or less, again, they showed good response in terms of PCR rate versus placebo with delta 29. The idea is that the higher the ER expression, the lower the PCR rate for nivolumab. And the same data for residual cancer burden category 0 to 1. Again, for BR, those patients who has BR less than 10% achieve good response to nivolumab, and those who has BR more than 10% achieve less response to nivolumab. And also the same story for residual cancer burden category 0 to 1. Now this patient, the other biomarker is Ki67, and this picture showed that there is no association between nivolumab benefit and Ki67 index was observed. So in summary, checkmate 7FL meet its primary endpoint, showing statistically significant improvement in BCR rate with nivolumab, and the higher magnitude of benefit was observed in patients with PDL tumor with Ventana 1% or more, and Nivo benefit on BCR and residual cancer burden category 0 to 1 rate was the highest in patient with tumor with higher CBS and tumor infiltrating lymphocyte more than 5% or more, and lower ER expression less than 50% and BR expression less than 10%. And increased BCR was seen with any tumor infiltrating lymphocyte, and high BCR rate were observed in patients with CBS score more than 10 and more than 20. And there, as I mentioned, there is no association between Nivo benefit and Ki67, and there is moderate overlap between Ventana and CBS assays, and the tumor infiltrating lymphocyte was observed, but additional exploratory and correlative analysis are ongoing to further refine the patient subpopulation with a primary ER positive, HER2 negative breast cancer who could benefit from the addition of nivolumab in the neoadjuvant setting. The last trial, I will just explore it quickly. This is phase 2 Nimbus trial, hypothesizing that immune checkpoint inhibitor in hypermutated patients who are HER2 negative might show potential benefit in this setting of patient. And we know that Keynote 158, pembrolizumab received accelerated approval for treatment of patients with unresectable or metastatic solid tumor with tumor mutational burden 10 or more. This is the study design, and they allow for one prior chemotherapy 1 to 3 line. They are all checkpoint inhibitor naive, and the tumor mutational burden cutoff is 9 or more. And those patients receive nivolumab 3 milligram per kg q2 weeks, and ipilimumab 1 milligram per kg q6 weeks till disease progression or unacceptable toxicity or until finishing 2 years. And the primary endpoint was to evaluate the objective response rate, and the secondary endpoint is safety and tolerability, and the clinical benefit rate, which is complete response or partial response or stable disease for 6 months or more. And we can see in patient characteristics that majority of patients, they are BDL negative, around 70%, and we can see that the tumor mutational burden, we have patient who has a tumor mutational burden more than 9, less than 14, or more than 14, or more than 20. See, we can see that the objective response rate here was, there is an objective response rate in terms of partial response with 16.7%, which is 5 patients. But also it is important to see that those patients who has a progressive disease represent around half of the patient. Let us look to the last column in this table. Those patients who has less than 14 tumor mutational burden, there are only 2 patients who represent 8% who achieve objective response rate. But those who has more than 14, 60% achieve objective response rate, which is 3 patients. So we can see that the median time to response was 1.2 months and the median duration of response was 12 months. And we can see that the median BFS was 1.4, as I mentioned, and the median OS was 19 months. And here we can see that the BFS and OS was better in patients with tumor mutational burden 14 or more in comparison to those who has lower than 14. Those patients who are alive, who achieve partial response, they are 100% alive, and half of the patients who have progressive disease, they are alive after 12 months. And there is no new safety signal, and there is no grade 4 or 5 adverse event in this immune protocol. And in conclusion, a combination of nivolumab plus low-dose ipilimumab in patients with HER2-negative metastatic breast cancer and high tumor mutational demonstrate an objective response rate of 16.7, and it meets its primary endpoint. And there is no safety signal, and the study support the use of immune checkpoint inhibitor for patients with metastatic breast cancer and high tumor mutational burden. But the question, but it doesn't answer the question if dual checkpoint inhibitor is better than pembrolizumab. And we have seen that patients with tumor mutational burden more than 14 were a minority in this study, but they achieve objective response rate of 60%. But we need further studies to look for this potential benefit to immune checkpoint inhibitor in such patient group. And with this, I conclude, and thank you.
Thank you, Dr. Mohammed, for the excellent review. Now we'll keep the question to the end of the session, and we'll move to the next speaker. It's my pleasure to introduce Dr. Leo. He's a consultant medical oncologist at King Fahd Specialist Hospital, Dammam. He will give us a talk about ER-positive metastatic breast cancer beyond CDK4/6 inhibitor. Please, Dr. Leo, the floor is yours.
Well, good morning, ladies and gentlemen. It's my great pleasure to be here with you today, and my great honor. Thank you for your kind introduction. I would like to thank Dr. Ahmed for inviting me, but I would also like to thank him for assigning me exactly the same topic with Dr. Ihab. No, it is an honest thanking, because although this is a very interesting topic and it's one of the highlights in all breast cancer meetings, however, the actual knowledge that we have about this topic is so limited, and the data many times are controversial. So I think I look like this guy with the small torch trying to illuminate this field. These are my disclosure. So in the next few hours, I would like to give you a brief introduction. We will cover what are the options for single-agent hormonal treatments post-CDK4/6. I will touch the combination options, and then we would review very fast the role of cytotoxics. So to start this journey, let's review the journey of a metastatic luminal breast cancer. So traditionally, we will start with a CDK4/6 plus aromatase inhibitor. Then we will give second, third, maybe fourth line of endocrine treatment. And when we decide that the tumor is hormonal receptor refractory, we will switch to chemotherapy. Although we have studied very well the progression-free survival in the first line, most of them, they have the same, we have not studied the post-progression survival, which is very important, and actually it might answer to us why we have these different results. So the first thing I would like to mention that there is a clinical spectrum of hormonal receptor positive disease. It's not all the same. Although these clinical definitions are arbitrary, that means that we don't have clear definition, but we know that there is a spectrum starting for the highly sensitive metastatic luminal breast cancer, those patients that have progressed many years after finishing adjuvant treatment, they have only bone disease, asymptomatic, then you expect a very good response. Going last to the likely resistant, which are patients that have developed progression while on adjuvant endocrine treatment, especially in the first 2 years, and have extensive visceral disease and they are highly symptomatic. All these patients, all this spectrum, have included in our trials, but they are clearly different. And although arbitrary, they are very clinical relevant. You see in this trial, in the Aurora trial, I don't know if I can point, no, I cannot, but if you see the PFS for endocrine resistant, it is 6.6 with 6.6 max for CDK4/6 inhibitors, and it goes up to 20, more than 2 years for patients that are naive or endocrine sensitive. So, and as we move to more sensitive, efficacy of CDK4/6 inhibitor increases. Don't forget, what are the phenotype in the adjuvant setting? It's not always the same in the metastatic setting. Actually, we have a 15% discordance in terms for the hormonal receptor status, so it is important to repeat the biopsy. So, very important slide. Here are the ESMO guidelines for how to treat luminal breast cancer. So we will start with a CDK4/6, unless we have a visceral crisis and an imminent organ failure, so we should switch to, so we should start with chemotherapy. On progression, we should check about the status of BRCA, and then we will give either, if PIK3CA mutant, to give fulvestrant plus alpelisib, if ESR mutant, elacestrant, if BRCA, PARP inhibitors, or if you have none of them, you can give an mTOR inhibitor plus exemestane or fulvestrant, or to switch endocrine treatment plus minus switching also the CDK4/6 inhibitor. And with this slide, I could conclude my presentation, say salam alaikum, and go home. Seriously? No. Unfortunately, things are not so clear. And in the next 2 minutes, I will completely degrade this slide. Let me show you how. First of all, the concept of visceral disease is already challenged by the right choice result. Second, mentioned by Dr. Ihab, should we wait until progression, or could we earlier change our treatment based on ctDNA, have a better outcome? Can we continue cyclin inhibition? I will touch this. How long is long enough? Nobody knows to decide if our tumor is hormonal receptor sensitive or not. We don't have clear definition. Mutations, where to test? Which mutation to test and when to test? Should we test in the archive tissue? Should we test in the plasma? Should we test in the initial sample? Should we test at progression? Which mutation should we test? Still, many things to be clarified. The HER2-low concept already presented. We have now a new phase 3 trial that challenges this dogma of TDXT, although the results were not so impressive like the Destiny-04 result. We have also sacituzumab for the concept of cytotoxics. In the United States, we have the AKT inhibitor capivasertib. Chemotherapy. For 20 years, from the late 90s to the late 2010s, we were debating in all our conferences which chemotherapy we should use after first-line endocrine treatment. Should we use a doublet? Should we use monotherapy? There are more than 100 phase 3 randomized trials in this setting. Personally, I have participated in 4 phase 3 trials, multi-center conducted only in Greece, trying to answer this question. I will not touch it at all. And last but not least, even the dogma of first-line CDK4/6 inhibitor are challenged by the SONIA result. So all this slide, it's completely a mess, to be honest. And we don't only have unanswered questions, we have also unmet needs. Because, as you know, the progression-free survival with the standard of care endocrine treatment is very low, and I will prove that. The standard of care was mainly fulvestrant, but we know that the bioavailability of fulvestrant is low, and there is an issue because it is an injection, and many of our patients are complaining. And the unanswered question when you use CDK4/6 in the first line, so when the patient progresses, is resistance to the hormonal treatment or to the CDK4/6? We don't know exactly. These are results. This is the standard of care arm in 4 randomized trials, 2 of them phase 2 and 2 of them phase 3. This is what we expect with fulvestrant alone. You could expect something from 1.9 to 3.7. Not really impressive. So the first question that I always like to try to answer when I have a patient post-progression is, does the patient I'm going to treat harbors a tumors that is still driven by estrogen receptor? If yes, should I use a single agent or should I will use a combination? And the third question is, if not driven, how and when we should switch to cytotoxics? So things are easy if you have a BRCA mutation covered elegantly by Dr. Osama. If you have BRCA, you can switch to PARP inhibition nicely. Just to mention one thing, you should be careful because the results for BRCA patients in the first line with CDK4/6 are clearly inferior compared to whole population. You could expect a PFS of around 1 year, 14 months, 9 months, which is clearly inferior to more than 2 years we have for the whole group. Okay? Maybe this is because we have a more aggressive disease. We don't have a clear answer about that. So let's see about what are the options for single agent. So for the single agent post-CDK4/6, our options come here with the search. Okay? Emerald trial presented very nice by Dr. Ihab. I will not focus because I don't have time. Please note that the results were better as the PFS1 in CDK4/6 was greater. The more treatment, the more time the patients have on CDK4/6, the better outcome goes with elacestrant in the ESR mutation subgroup. Remember, more than 50% of our patients will experience a very long PFS, so this treatment is very clinical relevant. The subgroup analysis presented by Dr. Ihab say hazard ratio for bone, liver, ESR, and PIK3CA. Although the results were worse for the commutation, the hazard ratio was, again, significant. I will not spend already this have presented. What I find really interesting is the results about P53. We consider these tumors are resistant. But you can see here that the hazard ratio was 0.3, 0.5 for elacestrant, and it was positive. Do we have other certs? Yes, we have the Serena trial, which tested 2 different doses of camizestrant, another cert inhibitor compared to fulvestrant, and the result was positive for both doses, regardless of dose, low and high dose. Another cert inhibitor, imlunestrant, although this agent does not work very well alone, if you combine it with either everolimus or alpelisib, you have very high response rate. What do you expect about toxicity. Usually they are well tolerated. You can expect nausea, diarrhea, liver function test increase. And we always discuss about grade 3 toxicity. Well, if you have attended the San Antonio a couple of months ago, and you heard the patients advocate that they have the time to speak there, they said, you always discuss about grade 3, but grade 2 is also important. Grade 2 diarrhea means 4 to 6 diarrheas per day. What will be your quality of life if you have 4 to 6 diarrheas every day for 2 years? Could you attend this meeting? I don't think so. So it's very relevant. It's very relevant. So other targets, PROTAC, CERCA, CERAN, for the moment we have very limited results and very early, phase 1, phase 2, we don't have solid evidence. But let's focus on this curve. Okay, this is the EMERALD trial. You see that more than 50% of the population progressed very fast. That means that there is a subgroup of patients that do not derive any benefit at all. But the curves separate late. This is clearly, those of us that we have studied clinical trials, that means that there is a subgroup effect here. Still, we don't know which is this subgroup. And consistently, we see better results with ESR mutations with SERT. We have poor results with standard endocrine treatment, and we still do not know who are the patients who need chemotherapy or the new monoclonal antibodies. Who are the patients that we can recover them later with a combination, to start with SERT and then go with a combination? We don't know. Let's talk a little bit about what are the options in combining hormonal treatment. First, about a few points about mutations. Not all mutations are happening at the same time. Some of them are present at diagnosis, like P53 and PIK3CA. So you can easily test even your initial tumor for PIK3CA. But others, like ESR1, HER2, and AKT, are acquired, happens later in the disease course. So for combination, it's all about genomics, okay? You have to check either in the tissue of the biopsy that you have confirmed the progression, or you can have a liquid biopsy. So if you have no actionable genomic alteration, you can offer either to switch CDK4/6 or to combine mTOR. If you have an actionable mutation, then you should give a PIK3CA, like alpelisib. What if you have used CDK4/6 as second line? Here is what you expect, a PFS of 6 to 8 months, maybe because of different study population. Do all of our patients need CDK4/6 in the first line? I'm not convinced that all of them need. Challenged very nicely by this independent trial. Why am I adding this? Because we have no data at all what we will offer if we could use CDK4/6 in the second line. Can we continue syncline inhibition? We have 3 phase 2 randomized trials, Maintain, PACE, and Palmyra trial, that have tried to answer this question. Results were controversial, but I think we can explain that. If you see the trial design of this phase 2 randomized trials, in the Maintain trial, after progression, they switched both. They switched the CDK4/6 inhibitor, but they also switched the hormonal treatment. In the other 2 trials, PACE and Palmyra, they switch the hormonal treatment only. They keep Palbo and they switch the other. Not surprisingly, these 2 were negative trials. Maintain was a positive trial. Can we apply these results in our everyday practice? I'm not sure, but it is something to consider. And be careful, this concept is not at all dead, because nowadays we're going to have our patients that are now receiving CDK4/6 inhibitors, and they are going to progress. So we will have to answer this question in the very, very, very near future. And this tried to be answered by this trial, the post-MONARCH trial, that allows patients also that have received CDK4/6 inhibitor in the adjuvant setting. Can we switch, or could we switch earlier based on ctDNA findings presented briefly by Dr. Ihab, but PADA-1 trial tried to answer this question. Started all with CDK4/6 palbo with an aromatase inhibitor. They were checking for ESR mutation every 2 months, and when they progressed and when they developed ESR mutation without clinical or radiological progression, they switched to the randomized palbo fulvestrant, switching the hormonal treatment or keeping until clinical disease progression. 2 points. The median time of developing an ESR mutation was 18 months, which is clearly shorter than the PFS you expect with the CDK4/6 inhibitor. But, not surprisingly, 40% of the patient population progressed without an ESR mutation. So the concept of ESR mutation is very promising, but it will not answer all the questions. And the PFS1 was very positive, but for me, even more promising was the PFS2. Like there is a carry-on effect. And the hazard ratio, the previous was 0.5, this was 0.3, and the difference was 14 months. And my question here is, what would happen if instead of using fulvestrant, we have used a SERT in this concept? I expect to be much greater benefit. What about targeting the mTOR, PIK3CA, and AKT? Okay, you all know this trial, Bolero trial, another standing ovation for late Dr. Baselga. It was the first non-chemotherapy option for second line, hazard ratio 0.36, clearly fantastic. We were all very enthusiastic at that point. And also the same if you use fulvestrant instead of exemestane, and then we start using the medication, and we were not so enthusiastic because it is very toxic. It is not an easy pill to swallow. Pneumonitis, stomatitis, all itis you can imagine you can have. I have very few patients that were able to tolerate full dose. Usually I have to low to 5 milligram. The good thing is that if you start giving the mouthwash earlier, most of the patients can be more time on treatment, but clearly it's not. I remember a patient, doctor, what would happen if you have given me chemo? It would be worse than that? They are answering. So what about the new PIK3CA inhibitor like alpelisib? I will not focus at all at SOLAR trial because in the SOLAR trial, none of the patients have received CDK4/6, and not at all for the first generation of PIK3CA inhibitors because although efficacious, they were highly toxic and they were all abandoned. So we have this BILIVE trial that tried to answer the question of the activity of alpelisib post-CDK4/6 inhibitors. We have the cohort A about that. And the results were very encouraging, 6 months of PFS. And
excuse me, 1 minute to conclude.
Give me 3. Side effects, very important. Hyperglycemia, 60%. And in this part of the world, where the incidence of DM is 2 or 3 times more than the rest of the world, it is very clinically relevant. You can combine these agents with all other SERTs still under investigator. AKT inhibitor, capivasertib, Capitello trial, second line post-progression of CDK4/6. Positive trial, alhamdulillah, FDA approved it only with AKT alter pathway and not for all, because I don't like at all when we have targeted agents that are receiving approval for all comers. It doesn't make any sense. Okay. There was no difference regarding the type of alteration. When we transition to cytotoxics, we have the concept of HER2-low presented very elegantly before. We have this new trial in San Antonio 2 months ago, positive also trial. We have the data from sacituzumab, heavily pretreated population. Some of them have received 4 lines of chemotherapy. Positive trial in terms of progression-free survival, in terms of overall survival after the second interim analysis, regardless of HER2 status, of course, and regardless of TROP expression. So this is now my one slide more to conclude. This is the journey. So you start with endocrine treatment, then you switch to single-agent chemo. If it is HER2-low, you can give trastuzumab deruxtecan. If it is HER2-0, you can use sacituzumab. Take-home messages. So, as in all fields of oncology, we should understand that all of our hormonal receptor positives are not the same. We should have that in our mind when we treat them. And for me, the most important factor that will accelerate our understanding and will improve our knowledge is our ability to identify different clinical and biological groups. The concept of endocrine therapy has changed forever. Use of single agent has limited benefits, but there are some patients that can still offer single agent. Combinations will be most likely the future. If you use combination, you have to base your decision on genomic analysis. Cytotoxics remain the standard of treatment for hormonal receptor refractory tumors. And my final thoughts. I show you this dark photo in my first slide. I think that as we understand more and more, I think that situation looks a little bit like this. We have to go through a stormy sea, but there is light at the end. So we will not treat our patients beyond CDK4/6 inhibitors, but we will start to offer him some life beyond breast cancer. Thank you for your attention.
Thank you so much. Dr. Chiles, please stay in the stage. We'll have a few minutes for question and answers. I would like also to ask the other speakers, Dr. Mustafa, Dr. Muhammad, to come on the stage. First, I would like to thank Dr. Ahmed for this kind invitation. Thank you so much, and thanks to the organizing committee, to the Moosa Health Group, as well as to the sponsoring pharma. We have a few minutes for a question and answer. Please, anyone?
Yeah.
Dr. Ahmed.
Well, I have a question for Leo regarding two things, actually. First of all, the maintain trial, you said that the maintain trial will have an impact, which is true, will have an impact in those who are receiving adjuvant CDK4/6 inhibitors. The question is changing, random changing. There is no testing, there is no ESR1 testing, just random changing. Is it really the right thing to do when we have now biomarker-driven treatments? Is it something that we should do? We give the patient the benefit of this PFS of a couple of months and then retest? Or no, we should probably go for what's more evidence-based and what's more biomarker-driven rather than a couple of months of guessing the treatment?
Well, if you ask me about the concept for patients that have metastatic disease and have started first-line CDK4/6, I will be with you. If you ask me about the patients that were receiving adjuvant CDK4/6 inhibitors, we don't have evidence. And at that point, you might consider switching not only the hormonal compound, but also both of them, CDK4/6 and the hormonal
Bear in
compound.
mind the inavolisib, the Inavo 120.
Sorry?
The Inavo 120, which is the PIK3 and upfront with palbociclib and fulvestrant. Right? The one that was just presented in San Antonio, PIK3 mutation upfront, first line.
Mm-hmm.
So that's what I'm saying. Even in the adjuvant, I think we still need to find the biomarker because that
That's
improves
true,
the progression-free survival.
What I'm trying to say that switching CDK4/6 inhibitors, it's not a dead approach. We should, I don't say that should be the standard of care, of course, but this is something, because it is a journey and you are going to treat these patients for many years. So putting aside completely doesn't make any sense. It is something that you can use it, of course, not in the second line, that was my topic, but it's something that you can consider later.
Sounds good. Sounds good.
You said two things. What was the second?
Well, the second thing is the chemotherapy. Is Xeloda worse than everolimus?
I'm not sure. I'm not sure.
You know, in Bolero 6, there is no difference in progression-free survival. It was more tolerated, so. More tolerated.
I agree.
It's very difficult medication.
We've been using it for a long time, not only for breast, but others. I think with 5 milligram, it's really acceptable, nice, and it's oral. You don't, metastatic breast cancer patients, the last place to want to go is to go to the hospital. If you give her something by mouth, she would love that. I mean, I've seen that, like capistabine preferred than, or navalbine preferred than other. So, and I like it actually. Why we're underestimating the combination of hormonal plus everolimus? Why? I mean, we can use it as a third line or even beyond that. But I mean, you say, oh, no benefit overall survival. But we get some benefit in progression-free survival.
We are not underestimating. I mean, according to the guidelines, mTOR inhibitors are the standard of care for patients that they have not a genomic alteration that we can target. Still, it is the preferred treatment for this type of patient, and I think that all of us were
even with people who have a genomic alteration, and we can't target as a second line or first line, whatever, but can be used. I know can be used at third line or fourth line. We don't have data about.
Of course.
We don't, but we have no option. This is what we use. Like TDM1 moved to the fourth line, or third or fourth, or probably fifth later on because we get TDXD. But there's no data trial. I mean, that using TDM1 versus whatever tucatinib as a third line. There's no, and will never be a trial for that. And the same probably applies for everolimus.
This is why I used the dark slide in the first slide.
Okay, can we have another question? Yes. Dr. Hashim.
Thank you very much. A question to Mustafa. I mean, now in HER2-low, we have more than one options of cytotoxic agents, including TDXD and SJ. Is there any biomarker so we can choose which one is better over the others, or how to choose between them?
So between the TDXD and SG?
SJ, yes.
So I think the biomarker is the HER2 expression. So for HER2-low, definitely I would prefer TDXD. And for triple-negative HER2-low, probably is to go for the SG because the HER2-low triple-negative in the Destiny-4 trial is just 60 patient and exploratory analysis. And SG work regardless of the HER2, whether it is HER2-low or not, whether there is TROP2 expression or not.
Is the level of expressions will change your managements? You know, HER2-low is variable from 10% till more, and with 2+. So yes, 2+, 1+. So this will change your management?
Wallahi, I mean, it's been shown that in the subgroup analysis that +1, +2 doesn't differ for the HER2. And for the hormone expression, I mean, there was no data about, about expression of ER, just all ER positive. So I don't have answer regarding the expression of the ER. So.
Okay, next. Yes, please.
So, I have a question for Dr. Al-Hassan. IO and ER positive, what we saw from all the trials, it's very clear, the theme is clear. The cancer that's resembling or more towards sides of triple negative and with high burden of the disease and with PD-L1 positive is the one that's responding. And targeting pathological complete response, the whole design of the trial and the difference between nivolumab and pembrolizumab, there's a lot of things that's not really convincing in those trials. So what do you think about IO in high ER positive, more than 10%? Okay. Is it something that you think in the future will be, we are using or not?
I think now because the trial still there is immature data, so I think more follow-up, we will see more exploratory, analysis. But in the future, I think the agent will be approved as an option beside other option which is approved like CDK4/6 inhibitor or PARP inhibitor in BRCA positive patients.
So you think now when you practice, if we see a patient where they are like 5% and high burden of the disease, we cannot use and PR or PR only positive, we cannot use immunotherapy in those patients? I think this data will help us to use immunotherapy in those patients, even it's not in the guideline.
Actually, we use.
We do, right?
Can I have follow-up question to that regard? Muhammad, if you have patient HER2 negative, but he is PD-L1 negative, and you have already NGS telling you that the tumor burden, mutation burden is low, would you still use immunotherapy?
I think I will look to other clinical pathological features, but generally we notice that those patients who has lower BDL positivity and they have higher hormonal positivity, they benefit, the benefit was less clear to immune checkpoint inhibitor. So the key point here is that I still have more data that I need to see to decide in these scenarios. Can I use it in those patients? In addition to that, in the two trials, some patients currently we will treat them with upfront surgery. So can we shift them to neoadjuvant? I think the key point is to wait for event-free survival for Keynote 756. And in CheckMate, in fact, their plan was to go for event-free survival, but with the approval of CDK4/6 inhibitor, they just leave it and they go with BCR only. So I have to wait more to decide really, and it's hard to say. And I think we can listen or hear from our expert here also.
Thank you so much, Dr. Muhammad. I think it's time to adjourn this very interesting session. Thank you so much. I will now invite Dr. Ahmed to give the final remark.
It's been an interesting 2 days. I'd like to thank you all. I'll start with the audience and our guests who came from around the country. شرفتونا وأنستونا. And inshallah, also I would like to thank our partners in pharma and the academic affair. I really want to thank the academic affair in the Moosa hospital. They did an amazing job. They are overwhelmed with many things, and they were able to show the meeting the way it is. This is hopefully will happen next winter. we'll have more fun next winter also. So thank you very much. We will have the lunch, and following the lunch, the nursing department will conduct a workshop for nursing and the management of cancer patient care. Well, thank you very much.
Okay, shall we start? Good afternoon, everyone. My name is Amr Kayali, and this is my colleague Aya Moreno. We are two nurses working in the medical oncology unit of the Moosa Specialist Hospital, and today we're going to be presenting a small nursing workshop about administering chemotherapy for breast cancer patients. So who can tell me what do nurses can do in taking care of patients with breast cancer? Anyone can answer, can pitch in? We have someone over there.
Good afternoon, everybody. I am Ali Al-Hamoud, Senior Oncology Al Jabar Hospital Center. So to start from the early detection of the patient and help him how to do breast self-examination and how will be encourage him for health assessment. And also end of that, the treated patient of his cancer, of breast cancer, will treat him with chemotherapy and biotherapy and target therapy. End of that, if he became the palliative, also will care the patient during the palliative care.
Okay, thank you so much for your input.
Welcome.
I totally agree with your answer, and to add more, we nurses are also involved in providing psychological support for the patient from the time of diagnosis until the end of the treatment. So can you flip the slide? So I will start with the first slide. I'm going to talk a little bit about what type of drugs that we use, the chemotherapy and the biotherapeutic drugs. I will go over them very briefly. We have several drugs that we administer for breast cancer patients, and these drugs can be administered according to the diagnosis of the patient. Like, for example, if the breast cancer has been caught at an early stage, or if there's any metastasis involved, or if the patient received several lines of chemotherapy. So it depends on the diagnosis. So it depends on the diagnosis and the treatment with the physician. So the first class of drugs that we're going to talk about are basically anthracyclines, and they include drugs like doxorubicin, liposomal doxorubicin, and epirubicin. Usually these drugs are characterized with the red color, or some patients like to call them the red devil, because they're red in color and flashy, and they usually attract. These drugs basically they belong to the anti-metabolite classification, and we usually administer them in the first cycle of chemotherapy in the breast cancer protocol, and they are administered concurrently with cyclophosphamide in 4 cycles. The other class of chemotherapy that we can administer for breast cancer patients is taxanes, such as paclitaxel, also known as Taxol, docetaxel, also known as Taxotere, and albumin-bound paclitaxel, which is also known as Abraxane. Usually taxane, it's involved also as a first line of the treatment in breast cancer, and it's also involved as a second line of treatment in breast cancer. The first line of treatment usually includes Taxol. It's basically administered after giving doxorubicin and cyclophosphamide. It's administered for a total of 12 cycles. And Taxotere and Abraxane usually are administered if the patient did not respond to the first line of chemotherapy and if there is any metastasis involved. In addition to that, we also administer platinum agents such as cisplatin and carboplatin. They are also included in the first line of treatment, and usually they are characterized with their platinum-based compound, where they basically affect a little bit like the kidney function test. Cisplatin mostly is more nephrotoxic than carboplatin. Carboplatin is less nephrotoxic. Moving on, we have vinorelbine, or also known as navalbine. It's usually administered in metastatic breast cancer, following by methotrexate and 5-FU, which are usually given as the last line of treatment if the patient did not respond to any treatment. Moving on to other drugs, we have the biotherapeutic drugs, which are also known as targeted therapy. They are called targeted therapy because they target specific markers in the in the breast cancer cells. We have several classifications. I summarize them into 3 classifications. We have the monoclonal antibodies, which are basically some antibodies that are they can be either human-derived or animal-derived, or sometimes they can be synthetic. They target certain receptors that are present on the cancer cells, such as the Herceptin, also known as trastuzumab, and Perjeta, which is known as pertuzumab. They target receptors that are called HER2 cell receptors. In addition to that, we have antibody-drug conjugates. Just to simplify what are antibody-drug conjugate, it's basically we administer a drug that contains an antibody, and this antibody carries with it a small chemotherapeutic agent. So this antibody will target a specific receptor on the cancer cell, and once it targets the receptor, it will release the chemotherapeutic drug. The purpose of the antibody-drug conjugate is to minimize the effects of chemotherapy. Instead of administering chemotherapy for the whole body and making the patient suffer with the side effects, we can administer this drug that can target one cell specifically. Examples of antibody-drug conjugates: we have adotrastuzumab, emtansine, such as Kadcyla, or also known as TDM1, and we have famtrastuzumab deruxtecan, which is also known as TDXT. And finally, we have kinase inhibitors, which are, I won't say rarely used. They are also used as a resort, as a last treatment in breast cancer, or if the patient did not respond to chemotherapy. They are known as kinase inhibitors. Basically, they function by blocking the kinase energy mechanism inside the cells, where they affect the cell growth and prevent the cancer from growing rapidly. In addition to that, we have some hormonal therapy. Some breast cancer patients are positive for hormonal receptors, such as estrogen and progesterone. And we have 2 types of hormonal therapy. We have aromatase inhibitors. Basically, these aromatase inhibitors, they work by stopping the conversion of one enzyme that transforms into estrogen. Examples include anastrozole, exemestane, and letrozole. And we have selective estrogen receptor modulators. Basically, they regulate the estrogen levels in the body of the patient, and sometimes they block the receptors. And they include drugs such as tamoxifen and raloxifene. Okay, now I'm going to leave the floor to my colleague Aya. She will be talking about the general side effects of chemotherapy.
Thank you, Ahmed. Hello, everyone. So first, we are going to start off by speaking about the general side effects of chemotherapy in breast cancer patients. First, we have hair loss, alopecia, nail changes, anemia and thrombocytopenia and neutropenia, mouth sores, loss of appetite or weight changes, nausea and vomiting, diarrhea, fatigue, nerve damage, hot flashes, vaginal dryness from menopause caused by chemotherapy, cardiac toxicity as seen with doxorubicin and Herceptin, and the development of secondary cancer, which is rarely seen, such as leukemia. So it is very important for us as nurses to know these side effects and to know how to treat them pharmacologically and non-pharmacological interventions, such as dealing with nausea and vomiting. We could instruct the patient to have dry, small meals throughout the day, not to push themselves to eat too much, to not induce more nausea and vomiting. We could also have at-home remedies, such as using peppermint oil to decrease the nausea and vomiting. So how can nurses provide psychological support for breast cancer patients while receiving treatment? I think because us as nurses, we are at the first line with the patients. We are in direct contact with the patients throughout their day. It is very important for us to realize and to acknowledge the importance of psychological support during the treatment of the patients in the hospital stay. So the patients will have feelings of depression, anxiety, and distress, which is mostly common in breast cancer patients because this is a new thing to them. Their whole lives have changed in the small course of maybe a few weeks. So the treatment will affect their appearance, their image, and their self-esteem. patients might view themselves negatively, as this is a huge stressor in their lives, and we can support them in many ways, such as gently invite the patient to speak about their feelings. We should not force the patients to speak about their feelings if they are not ready. Every patient has their own pace and their own time. As I like to say to my patients, a healthy mind means a healthy body. We should listen carefully to the patient's feelings, and we should not judge them. We should not invalidate them. If the patient is feeling this way, we should not disagree with their self-defeating thoughts. We should avoid telling the person to just cheer up or think positively. Us as nurses with the patients and their family, we can decide together what kind of support the patient needs, what we can do to support each other and to help the patient to use their activities that they enjoy, to continue their daily life, even though they are staying at the hospital. So if the patient reaches a level of high fear, anxiety, or depression, we should, of course, get help from someone from the cancer team. We should also keep in mind that us as caregivers can become depressed, and all these suggestions do apply to us. We should also take care of ourselves so we can take care of others. So what are the most common diagnostic tests that are frequently used in diagnosing breast cancer? First, we have mammograms. It is the type of imaging which uses X-rays to detect any type of abnormality in the breast, and this is the most commonly used to diagnose the breast cancer. After that, when there is something abnormal shown on the mammogram, we can go for a breast biopsy, which is done when the abnormality is detected in order to confirm the diagnosis and which type of breast cancer. We have the breast ultrasound. It is not usually used as a routine screening test. It is only used when the tissue is very dense and the abnormality is hard to detect on the X-ray. Lastly, we have the breast MRI. It is recommended screening along with the yearly mammogram for high-risk patients. However, not all MRI can detect the abnormalities that the mammogram usually will detect. So for self-assessment of the breast, it's very important for us as nurses in the community to give awareness for everyone around us to conduct self-assessment. Little evidence has shown the effectiveness of self-examination in detecting breast cancer, but usually breast cancer, the first symptoms that will show is a lump that is detected on the breast and discovered suddenly. So women should be familiar with their bodies and report any abnormal changes that they might discover. Thank you. Any questions?
Any questions or something you would like us to discuss more? Leila?
Thank you so much for the informative nursing workshop that you give for us. I have just a few questions when it's come for the side effects of the chemotherapy. We mentioned that patients will experience hair loss, nausea, neutropenia. Is it necessary with all the type of chemotherapy that the patient is going to experience all this type of the side effect or not? And what is what's depend on? Is there any other factors that patients may not have this much of side effect compared to another patient with the same stage of cancer?
That's a very good question. We forgot to mention something very important. Usually chemotherapy, they have general side effects. However, there are some chemotherapeutic drugs that are stronger than the others. Like for example, if we take for example cisplatin, doxorubicin in comparison to Taxol, they can cause neutropenia more than Taxol. It's one of the side effects that they cause bone marrow suppression. Taxol doesn't cause frequently bone marrow suppression. This is one. Two, also the diagnosis plays a role. Like we need to see if the patient has any metastasis, for example, that involves the bone, or in the bone marrow in particular, if there's any metastasis in that area. So definitely the patient will be suffering from neutropenia, thrombocytopenia, and anemia. And as for hair loss, not all chemotherapeutic drugs cause hair loss. Some of them they cause hair loss. Some don't. Some they make you lose some small amount of hair. That's it.
Thank you for all. You mentioned that's one during psychological support. You said avoid telling patient they think positively. Can you give me more explanation about that?
I'm sorry, can you repeat your question?
There is one point during psychological support for the patient. You said avoid telling the person to think positively. Can you clarify that some more, please?
Hello. In this point, this is when the patient maybe is talking about their feelings and they are sad and they are complaining to you. So we should not disregard their feelings and invalidate their feelings and just say, think positively or cheer up, it's fine. This is what it means.
Any more questions?
Thank you so much.
Thank you so much.